please check. Can you hear? Some Professor Kono cannot attend this meeting now. He asked me how to enter this conference. Someone can check Professor Kono's situation. He is in the audience.さっきまでちょっと喋ってたんですけども、今もう音楽が始まっちゃって、パーティシペントの人が、人がいなくて。
Ladies and gentlemen, it gives me great pleasure to welcome all of you in this series of webinars I'm organizing as second Vice President of the World Federation of Neurosurgical Societies in collaboration with the Continental Association of African Neurosurgical Societies and the Egyptian Society of Neurological Surgeons. Important to mention that we already organized 42 webinars, 10 of them are educational WFNS symposia since the beginning of COVID-19 pandemic. This is webinar 43 and it's done in collaboration with the Complications in Neurosurgery Committee of the World Federation of Neurosurgical Societies. And I would like to thank Professor Kiki Torel, Chairman of the Complications in Neurosurgery Committee of the World Federation of Neurosurgical Societies, for giving me such opportunity to work together. I'm actually honored by this collaboration. Let me welcome all our keynote speakers. Professor Miguel Araiz is Chairman of the World Federation of Neurosurgical Societies Foundation, and he's Chairman at the Department of Neurosurgery, University of Malaga, Spain. Tetsuya Guto, Department of Neurosurgery, Santa Marianne University School of Medicine, Kawasaki, Japan. Professor Frederick Poop is Chairman of the Department of Neurosurgery, University of Tennessee Health Science Center, United States of America. Professor Michihiro Kono is Department of Neurosurgery, Tokyo Medical University, Tokyo, Japan. Professor William Caldwell is Chairman of Department of Neurosurgery, University of Utah, United States of America, and is President of the World Academy of Neurological Surgery. Professor Henry Schroeder, Chairman of the Department of Neurosurgery, University of Medicine, Greifswald, Germany. Professor Salman Sharif, Chairman at the Department of Neurosurgery, Liaquat National Hospital and Medical College, Karachi, Pakistan. Professor Yadram Yadov is Director of the Super Specialty Hospital and School of Excellence in Neurosurgery, Medical College, Jabalpur, India. And Professor Mazda Turel, he is affiliated to the Department of Neurosurgery, Wock Hard Hospitals, South Mumbai, India. Thanks to all of you for contributing to this neurosurgical activity and for giving us much of your time and experience, sharing your knowledge and experience with young neurosurgeons, especially at this difficult time of COVID-19 pandemic, is well appreciated. This webinar is divided into 3 sessions. All the topics are very interesting. The first session is about complications in neuro-oncology. second session about complications in the skull-based surgery, and the third session about complications in spine surgery. Until yesterday, we have 315 registrants over Zoom. We are also doing live stream over our Facebook page of CANS. This is the address you can see in the screen. And over the YouTube channel of the Egyptian Society of Neurological Surgeons. And we are also doing live stream over the Neurosurgical TV of John Bennett. For all attendees, we are glad to get all your questions and comments, and it will be monitored through the chat panel or the Q&A. We are offering certificates. This is the type of certificates we are offering. Remind all of you that this event is organized by the World Federation of Neurosurgical Societies, and this certificate is approved by the World Federation of Neurosurgical Societies. Please write this link. I will leave the slide for a few seconds. This is the link by which you can print your certificate electronically. And you can put the username is going to be the email by which you register to this event. And this is the password as shown in the screen. Don't wait. We don't send any certificates by email. You can print it electronically. However, just give 1 week after the meeting in order to give a chance for the organizing team to upload the emails to our system. Let me announce about next Friday event is going to be webinar number 44. It's going to be a neurosurgery plenary session. We have also eminent speakers, Professors Kenan Arnautovic, Mario Amirati, Jer Russo, Claudio Jampolsky, Richard Byrne, Andrea Dimitriade, Jorgen Honiger from Germany, Alessandro Perin, Hazim Tahawi, and Nicolo Merchasin. Important announcement also that we are organizing the Third Men's Congress, which is the Congress of the Mediterranean Association of Neurosurgical Surgeons in Egypt, October 27, but probably it's going to be postponed to next year because of the COVID-19 pandemic. All of you are invited to participate in this important event. Maybe it's going to be a good opportunity to visit together the Grand Egyptian Museum. Thank you very much. Now I give the mic to Professor Kiki Torel to say his welcome speech.
Yes. Good evening, friends. Welcome to today's scientific session on neurocomplications. As you heard, the focus is on complications, which is a secondary disease or condition which makes an already existing one worse, something more intricate, difficult, or confusing, an unfavorable evolution or consequence of a disease or health condition or therapy. Every disease management is liable to complications, surgical treatment even more so, because of direct invasion of the body. And of all surgical endeavors, neurosurgical consequences can be truly devastating. And they occur in everyone's hands at some time or the other, not only in the initial years of training or surgical practice, but even after many decades of experience. So no surgeon is really exempt from it. It may not be directly related to the surgical skill of the neurosurgeon, or it could be misinterpretation of images, wrong patient selection or wrong approach, improper positioning, unprecedented anatomy or bleeding, equipment failure, or simply an insurmountable disease. Surgical success is usually expected and it is taken for granted. There's nothing remarkable about it, as you know, and it fades away in one's memory, but it boosts a surgeon's ego, but teaches nothing, and in fact makes him very haughty. The real education and improvement comes by looking at our complications and failures and learning from them. That makes you humble. Complications, they stand out, haunt the surgeon's life, and leaves him with ugly scars and lessons to learn. That precisely is the reason why we surgeons should get together to honestly and openly discuss our mishaps, mistakes, or failures, and by doing so, learn from each other for our own good, and that also for our good of our patients. It has been said, it is better to stay out of complications than to get out of complications. A reflection of an old adage, an ounce of prevention is worth a pound of cure. Everyone understands that it's easier to stop something from happening in the first place than to repair the damage after it has happened. In our context, the two sides of the coin of complications are anticipation or prevention and management. As Professor Nasser said, our 3-hour webinar today has been divided into 3 segments: neuro-oncology, skull base, and spine. And we have heard about these 9 eminent speakers, 3 in each segment from 6 countries, from east to west: Japan, India, Pakistan, Germany, Spain, and USA. Professor Nasser from Egypt and I from India will moderate. Most of these talks will discuss prevention, anticipation, and avoidance of complications encountered by them, by these very eminent people on one hand, and on management of the other. Let me end by saying success is not built on success. It is built on failures. It's built on frustrations, and sometimes it's built on catastrophe. Whilst we may savor success, we learn only from failures, and failure is a defeat only if you don't learn from it. That is the carry home message. So, ladies and gentlemen, let's start with our webinar with this brief introduction and get on to our first speaker, and that is my dear friend Miguel Arraez, who will talk about vascular complications in skull-base surgery. Thank you, Miguel, for gracing this occasion and for giving us the privilege of your knowledge and experience. Thank you very much.
Thank you very much to you, of course. One second. I hope you can see my screen and you can hear me. Is that correct?
Perfect.
Yes.
Thank you very much. First of all, to Professor Nasser El Gandour, Professor Keki Turel, great neurosurgeons, great friends. Thank you very much for this utmost kind invitation. It's for me a great honor and great pleasure to participate in this outstanding initiative of talking about complication. That is one of the most important and educational from the educational point of view, one of the activities with a big impact in the education of young neurosurgeons. So my topic is about complication in skull-base surgery, major vascular injury. As a very brief introduction, if we just click in PubMed skull-base surgery, we will see more than 15,000 entries. If we click skull-base surgery complication, more than 6,000, and skull-base surgery vascular complication, more than 1,000. It means that in 1 out of 15 publications in skull-base surgery is regarding vascular complication. So we are talking about a very important issue. Just to remember, this is the way the plane are crashing. There are a lot of simultaneous and unfortunate situations that finally are leading to the crash of the plane. But in surgery and in vascular lesion, unfortunately, we only have one chance. We don't have such a 3, 4, 5 possibilities of avoid the complication. So let's start with this case. I just make, I prepare several cases. Case number 1 is a 57 years old patient with left cavernous sinus malignant meningioma, operated on, and just after that receiving radiotherapy. And 1 year later, the patient started with right optic nerve invasion. This is the MRI, and the last MRI tumor almost not seen in MRI, but progressive optic nerve compression. So we did this sort of decompression by means of a simple tellurial approach. This is the ultrasonic drill. This is the way we are just cutting the dura. You can see the dura infiltrated. We are at the right side, so we are just cutting at the lateral aspect and see what happened. Fortunately, we managed to coagulate this small vessel that was the ophthalmic artery. And this complication that fortunately was solved, but could be a very severe one due to the laceration of internal carotid artery, was due to anatomical variation in the origin of the ophthalmic artery. And this case is especially, for the youngest colleagues in the audience. We have to pay attention to the possibilities of variation regarding the origin of the ophthalmic artery. We don't have to have a fixed idea about the origin, usually at the internal aspect, inferior, medial aspect of internal carotid artery. There are several publications talking about anatomical variation in the ophthalmic artery, but this is not a classical topic. If we look at this paper published in Neuroradiology, it has been published in 2020, and we can see another publication, 2019, 2020, double ophthalmic artery arising from internal carotid artery, and another publication in 2020 talking about new variants. So possibilities are many, and we have to be very aware of that, because the ophthalmic artery may arise even from the meningeal layer instead of the internal carotid artery itself. And this sort of ICA injury is falling into this category. There are several categories. First one, anatomy related, that could be due to the recent ICA canal, variation in sphenoidal septal, short distance between ICAs, and this is the category vessel wall abnormalities and anatomical variation. Let's see case number 2. This is a patient, 14 years old, operated on due to chordoma. I operated on this patient in 2000 in my former institution in Granada. You can see this chordoma. At that time, 2000, we did the operation by means of open door maxillotomy, and we had this satisfactory result in the sagittal view. Some remaining tumor, you can see here, top on right, just removed by means of a complementary far lateral approach. The patient received radiotherapy, and in 2014, that is to say 14 years later, the patient came back with this recurrency at the petrous apex and parapharyngeal space. At that moment, 2014, we were already involved in endoscopic surgery, and we just planned this parapharyngeal endoscopic approach to the petrous apex and parapharyngeal space. You can see the relationship with the carotid artery. You can see internal carotid artery, the lesion, and unfortunately, during the drilling of the petrous apex, the carotid artery was lacerated, and we took the patient. After that, we put a Foley balloon, trying to control the hemorrhage. We just took the patient in emergency basis, of course, to the angiography ward, and you can see the initial angiography. You can see the balloon that is compressing a little bit the internal carotid artery, but not enough to control the bleeding. This is the leak of the bleeding. We just had the opportunity to see that fortunately there was a good collateral flow, and the interventional radiologist sacrificed the involved carotid artery, fortunately without any neurological consequence. And this sort of complication is falling into category number 2, pathology related. There are several factors that are increasing the risk of internal carotid artery damage. Displacement by the lesion, adherence of the lesion to ICA that may occur due to previous extended surgery or previous radiotherapy. In some cases, bromocriptine therapy is also increasing the risk. high-risk lesion when there is encasement of internal carotid artery or need for wide exposure. It was the case, that is to say, 2 or more segments of the ICA involved by the lesion. See case number 3. This is a patient with acromegaly recurrency. We just planned reoperation by means of endoscopic transsphenoidal approach. We very seldom use neuronavigation in de novo cases because in pituitary lesion and many other lesions along midline, I think that anatomy is guiding you very well, but we always use neuronavigation for recurrency cases. What happened in this patient? This patient was at the, you can see the sagittal view, can have some idea about the adherence and scar from previous operation, distortion of anatomy. In that case, the patient inside the operating room, neuronavigation didn't work, but the patient had been at the waiting list for a long while, and we decided to continue and go ahead and see what happened in one of the maneuvers. Unfortunately, some massive bleeding from the right cavernous sinus. We managed to control that with flocine, again, Foley balloon, and some patient. The patient didn't have any neurological complication and not problem regarding, you know, acute anemia or something like that. But at the immediate, the patient recovered very well, but we did this CT angio just in case, and we had the opportunity to see this pseudo aneurysm that was due to the laceration during the operation. So we learned the lesson because this is a case falling into category number 3, skill, resources, inexperience. Well, I've been involved in pituitary surgery for more than 20 years and skull base for almost 30 years. I think I have some experience, but we made a wrong decision just getting involved in that case without neuronavigation with a case that was involving cavernous sinus. So in that case, lack of inadequate instrument and equipment, it was the case in our patient, and I learned the lesson very, very well. So let's see case number 4 very quickly. This is a patient, 20 years old, with pituitary adenoma. This is a de novo case. So according to our rule, no neuronavigation needed. But look at this MRI. You can see a flat cella here, almost flat in the coronal view. And this is something very risky. See also asymmetry in both carotid artery. And as we all know, endoscopic surgery is very good, very nice, but the distortion can be a big problem in cases like that, because you completely lose the perspective of the variation of the anatomy, and in that case, it led to intraoperative laceration of the left ICA. We took the patient to the angiography ward after tamponade with Flocil and Surgicel and Foley balloon. I have to mention that the bleeding was not excessive and we just controlled very easily, but in any way, we took the patient to the angiography ward, and you can see some narrowing here due to the intraluminal hematoma. MRI was nice, showing some narrowing, some small infarction without any neurological consequence, and the patient was discharged with clopidogrel, and this is angio MRI. This is 1 month after and 1 year after, and angio MRI deemed to be normal. Again, just the issue related to the anatomy. In that case, the cellular anatomy. In that case, the mistake of not using neuronavigation with a cellar floor. So this is something we have to learn. In our experience, neuronavigation in de novo cases not needed, let's say in more than 95 of the cases, but in some cases we have to look at the anatomy and be ready. So talking about some summary regarding major carotid injuries in skull-base surgery. The way of controlling arterial injury, sacrifice 80% of the patient will tolerate ICA sacrifice. We have to mention something about the role of the balloon test occlusion and neurophysiological monitoring, but we have to mention that we didn't do that in the two cases I have shown. This is taken from this very good publication from the group of Pittsburgh, Dr. Gardner. Second consideration, according to this paper, regarding the possibility of bypass. I think this is something we have to take into account, but I have never thought about that. Bypass, prophylactic bypass, we have never done that. Emergent bypass, we are not ready to do so. This is the honest consideration. But insofar as you are reviewing your cases and reviewing the reason you made the mistake and the possibility of avoiding that for the future, the issue of bypass has to be put on the table. Third, very important, the vessel preservation techniques. Bipolar electrocautery only indicated in avulsion of a small vessels or when laceration is very small. Aneurysm clip can be an option if you cannot control by means of this previous procedure. Take into account that regarding the potential question, what is the best tissue, what is the best substance for packing muscle, crush muscle is the best for packing because it's provoking the best potential healing of the involved vessel. Suture is a possibility, but for that, if you are doing endoscopic skull-base surgery, is very difficult from the technical point of view, and even more if you didn't happen to expose enough the vessel. This is a very good summary regarding ICA injury. Avulsion of perforator, bipolar coagulation or clip could be a good option. Direct laceration, small, you can obtain bipolar or aneurysm clip. If it is about a large laceration, we have to consider the possibility of occlusion or muscle pack. Of course, this is regarding intraoperative procedure to control the bleeding that can be a terrible problem. Immediate angiogram, and according to that, the possibilities of endovascular management. We have seen several examples, unfortunate cases, but fortunately all solved without any major issue from the general situation of the patient or neurological aspect. We have seen the possibilities for active extravasation, the possibility of controlling that. Also the management of pseudoaneurysm, and also we have to take into account the possibility of ICA stenosis from packing. We saw the Foley balloon in the second case that was provoking some sort of control or some sort of occlusion. So take it into account that if you intraoperatively pack and control the bleeding, maybe at the same time you are provoking ischemia. I don't think I have time for the case number 5, that is regarding open surgery and craniopharyngioma. And our philosophy regarding that, we just advise craniotomy when the patient had received radiotherapy and or craniotomy because of the high possibility of scar and high probability of damage not easy to be controlled by means of endoscopic procedure. So this is the summary of the possibilities we went through, and this is my last slide, just to take home a message for the junior colleagues. I see many senior and expert skull-base surgeons in the panel. They don't need that slide, but for the youngest colleagues, please take into account variation in anatomy, the characteristics of the tumor, important strategy in case of rupture, just to solve the problem of the vessel or try to avoid the continuous bleeding, regarding the muscle at the best potential hemostatic agent, and finally the role of endovascular management to solve that kind of complication. This is my last slide. I don't want to finish without thanking again my very good friends, Professor El Gandur and Professor Curel, the kind invitation. And I just wish you a very nice weekend. Thank you very much.
Thank you very much, Professor Miguel Areis, for this very interesting presentation. I think, Kiki, we have discussion at the end of each session for 10 minutes. And I think you can introduce our next speaker.
So actually, I'm wondering if Dr. Boop, he's in a hurry to go for surgery. And if he can be just asked to step in, he's the next speaker, but he just wrote to me that he's in a hurry to go for surgery. Would
you replace your talk with Professor Boop? Would you kindly replace your talk and let him speak now? Professor Goto.
Yes.
Is Dr. Boop around, please?
Yes, so thank you.
As Dr. Boop, Dr. Goto, can you just wait for a second? I'm just wondering if Dr. Boop can.
Okay, I see.
I'm sorry, perhaps another time. Yeah. No, Dr. Boop has left for surgery. He could not wait. He could not wait. So yes, okay. Dr. Goto.
Yes, I just start. I can start. Yes. First of all, it is a great honor for me to present here, and I appreciate to Professor Caldwell to give me a chance of these presentations.
What do we have problem in the voice? The sound is not clear. Is there any sound with this video?
Cannot hear my voice.
No, this video is with sound, with voice, or no? Because we couldn't hear anything.
Okay, I will change the.
Would you put the sound on, please? You can adjust it from the settings.
Okay, I'll change the presentation style to PowerPoint. Sorry. Sorry. Can you hear?
The sound is not clear.
Okay, sorry. I'll present without sound. I'll present the two cases of my complications. Patient 1 is a 70 years old man, and pre-operative diagnosis was left triangle renal cell carcinoma. He's have a slight dementia and sensory aphasia pre-operatively. Pre-operative KPS was 70%. At first, present his pre-operative angiography shows the Main feeder is anterior and posterior choroidal artery, and small some vessels feeders into the tumor. I'll remove the after anterior choroidal artery obliterations. At first, the craniotomy is opened to subtemporal and mild partial posterior petrosal approach is attempted. After a corticotomy of the inferior temporal gyrus, we reach to the inferior horn. Here is the inferior horn, and choroidal fissure is opened. Now you can see the diencephalix and telencephalic small branch and anterior choroidal arteries in ambient cisterns. After full exposure of the choroidal plexus, we try to cut the choroidal plexus with anterior choroidal artery here. I obliterate these vessels without temporary occlusions because here is the only in the choroidal plexus. But several minutes later, SEP and MEP is deteriorated severely, and we checked intraoperatively cannot change the monitoring findings. Post-operatively, the Abbey syndrome happened, and he had a severe right hand paralysis and worsening of sensory aphasia. Of course, the sensory aphasia is improved gradually, but the hemiplegia is not improved. Of course, many you know the anterior choroidal artery has the three branches: telencephalicus branch and diencephalicus branch and choroidal plexus choroidal branch. My previous anatomical knowledge in the cisternal portions, telencephalic and diencephalic, and in the ventricle in the choroidal plexus. After entering the choroidal fissure, that is a safe point because the choroidal branch never to I have a diencephalic branch. That is not true from my experience. In the natal delivery, anterior choroidal artery has two divisions: cranial divisions and caudal divisions. It means the cranial division is telencephalic branch and caudal division is diencephalic and choroidal branch. That is very near. It is a slight different of anatomical presentations. What is the plexus point? Anterior choroidal artery is like this. That is Uncus branch, and after entering the choroidal fissures, some branches can supply to the diencephalic branch. But I think this figure is not right because there are no diencephalic branch in the choroidal branch of anterior choroidal artery. Now, my understanding of a choroidal branch is like this. Plexus point is usually entered to the ventricle and no branches of the diencephalic branch. But like the right figures, you can see the plexus point is not the first plexus point. Plexus point is just before the passing point of a choroidal branch. That can understand my complications. Care must be taken for Abbey syndrome even if the choroidal segment of anterior choroidal artery is secured. Plexus point of anterior choroidal artery may not be equal as passing point of choroidal fissure. Safe obliteration of point of anterior choroidal artery is not a choroidal segment, but peripheral part after branching the diencephalic branch. MEP and SCP should be checked. Next case is 39-year-old man, and diagnosis was right lobar cranial neuronoma. He presented drowsiness and gait disturbance, progressing visual disturbance, and he was admitted semi-emergency. At that time, his KPUS was 50%, and bilateral severe papillary edema, and left eye is already blinded, right side is also deteriorated. No lower cranial pulses. He was operated and only 50% is removed. But because of the lower cranial nerve is behind of the tumor. But my topics is not my poor surgical result. After surgeries, his persistent consciousness disturbance and progressive visual impairment is presented. Although he was managed under spinal drainage. His spinal drainage was set in 10 centimeter H2O, and output was 200 milliliter, and protein level was remarkably increased 700 milligram. After the POD10 VP shunt was performed, and his conscious level is remarkably improved, but persistent of visual disturbance, visual impairment is persistent. I want to understand why the visual impairment was progressed under spinal drainage. In Pascal principle, we already know the from everywhere the spinal CSF pressure can be checked in same values. This is the Pascal's principle and hydrospheric pressure. But we neurosurgeons know to manage the ventricular drainage and spinal drainage to set the same values. Usually, ventricular drainage is, can obtain much flow volume, and the spine is small. Because of this reason is narrow and long drainage tube caused by the viscosity and velocity of CSF. It can be explained by flow dynamics theory. Flow dynamics theory is not so difficult. The relationship between flow volume and tube can be understood from these figures. In the reservoir and tube is changed to narrow. When the reservoir pressure is same, output flow is decreased, and changed to longer, the volume is changed to more smaller, and viscosity is higher, further flow volume is decreased. In the same principle can be explained on the other side. To obtain the same flow output, the higher pressure is necessary. It means the flow output poor. And in the spinal drainage tube outflow can be calculated by Deleuze-Weisbacher and Hagen-Poitier flow. Head loss or and pressure drop can be explained by Darcy friction factor. And Darcy friction factor is inverted corrected of Reynolds number. And we can gather this formula, and delta P, it means the pressure drop can calculate with mean velocity and viscosity and length of the tube, and inversely correlated with the inner diameter of the tube. We understand the some number, Silascon's ventricular drainage tube length and inner diameter, and spinal drainage is slightly smaller in the diameter. That is small changes, but from the viscosity of CSF can dramatically change the pressure drops. It means the viscosity of the CSF is correlated with the protein concentrations. Usually, CSF concentration is less than 15 milligram per milliliter. It means almost the 1.5 millipascal a second. But the protein concentration is 315. The viscosity is changed to the 90 point. My patient was over 700 milligrams. It means the viscosity is more higher than this. And these number enter to this formula. And when the CSF is normal, the spinal drainage pressure drop is can be calculated as 4 centimeter H2O. That is very small change of the in normal CSF protein concentrations. But when the protein is increased to 300 milligrams, it changes to the about 25 centimeter H2O. It means when to the spinal drainage is set on 10 centimeter, protein level is 300 milligram, means we manage the intracranial pressure is 35 centimeter H2O. In this patient, protein level is 700 milligram concentrations. It means over 50 to 60 centimeter H2O management, and it means the progression of the visual disturbance is occurred. Flow volume decreased in narrow and long tube and with highly viscosity flow. High pressure is necessary to obtain same flow volume in the narrow and long tube. Pressure drop is proportional to velocity, viscosity, and length, and it's inversely proportional to cross-sectional area of the tube. When the spinal drainage is set the 10 centimeter H2O, CSF protein is 300 milligram, and daily CSF output is 240 milligram. The intracranial pressure can be calculated as 35 centimeter. Thank you very much for kind attention.
Thank you. Unfortunately, Dr. Boop has left for surgery, so he is not in a position to participate in this. I don't know if he finishes his operation on time and joins us later, but at this moment, we are without him, so we can have the discussion on these two papers. So we have actually sufficient time for papers with Dr. Miguel Arraez. Are you there, Miguel? Is Miguel around to answer any questions? Hello, Miguel. Is Dr. Miguel Arraez there?
Professor Miguel Arraez, can you hear our voice? He's still joining, and we have some questions over the chat panel until he is going to unmute his mic, but he's still in the meeting. Kiki, we have a question over the chat panel. We can proceed until Miguel joins again.
Yes, let me see the.
I think Miguel already joined.
Miguel has come. Yes, Miguel. So the questions for.
Well, we have
there are no questions
from
in the chat.
Muhammad Tahir, any size of internal carotid artery tear to sacrifice? Any size of internal carotid artery tear to sacrifice? This is a question from Muhammad Tahir. Miguel, would you answer this question? Miguel, would you unmute your mic, please?
Sorry, I'm back.
Thank you.
So please, what is the question? I do apologize because as my good friend Nasser knows, we are just about to start one of the celebration of the year, that is the farewell party for the resident who is finishing. So I'm just
Yes.
science and amusement at the same time. I beg your pardon for that, but I didn't want to miss this webinar. So
Thank you. Thank you.
Sacrifice of ICA. So what is the question? Sorry.
The question.
What
So Kiki, can you say the question?
is the size of the tear required? What is the size of the tear needed to sacrifice the ICA after it is injured?
Sorry.
That's
Sorry.
what the question is. The size of the tear related to sacrifice of the artery.
Yeah, well, I think the issue of the sacrifice, if we are the sacrifice of the ICA, I think is just very much related to whether or not you are able to control the bleeding. If you are able to control the bleeding, there are two parts. Intraoperatively, you can control the bleeding, is okay by any measure. You have to control the bleeding, and then just taking the patient to the angiography ward and see how the lesion is or what you can do, depending on the exact place of the tear of the carotid artery. You need to sacrifice the carotid artery. You would need to sacrifice, or you can put some sort of stenting or pipeline, but it depends on the segment. So if you are able to control the bleeding inside the operating room without sacrifice, perfect. If you take the patient to the angiography ward, you will see at the angiography whether or not the measure is able to control the leak, because by means of the angiography you can see whether or not there is still leaking or not. So according to that, you may sacrifice or not carotid artery. Another important issue is the issue of the collateral flow by means of the communicating arteries. If you have a very good collateral flow, you can sacrifice carotid artery. If not, you are into a big problem.
Yes. So let us say you have managed to control by whatever way, without sacrificing the artery. If you just manage to control, you would invariably do an angiogram later on, at least, to ensure that there is no pseudo aneurysm. It was invariably, once there is a tear, even if you succeed in stopping the bleeding, you may possibly have a pseudoaneurysm. So you would do an angiogram as early as possible and attend to it. Is that correct?
Yeah, well, actually, if you are in such an acute situation of the very active bleeding, what you will see is probably the tear, not pseudoaneurysm. Pseudoaneurysm we have seen when you have a bleeding, you stop the bleeding, you think that everything is all right, but when you do angiography or you do CT angio, as we did in the case of the acromegaly, you see how some pseudoaneurysm has been formed. Pseudoaneurysm, let's say, is a lesser degree of severity, but also worrisome, of course. If you have active bleeding because of important tear, you cannot see an aneurysm, pseudoaneurysm. You see just the tear.
So how do you use the Foley's balloon? Do you use it from outside, like an external ball, and like a tamponade? You use the Foley's balloon for tamponade?
Yes, yes. What we do is just you are looking with the endoscope through the, let's say, the right nostril usually, and I take with well, fortunately I didn't have to do that many times. but sometimes actually, and I take the tip of the Foley balloon, you put the tip, and you take with forceps the tip, you put inside a sphenoidal sinus, someone is pushing the catheter in order to have, let's say, the whole balloon inside, and then you conflate the Foley balloon. Before that, you try to, of course, apply Flocil and Sargicel and all this sort of, or muscle for package, and just insofar as you inflate the balloon, you can have a very good result.
Yes. Yes, there is a question which Dr. Yadav has asked, and that I think you already answered. Is there a possibility to preserve the artery by using a flow diverter or stent placement in the carotid rupture?
Well, actually, yes. This is the ideal situation, but sometimes you cannot do that. You cannot do that because of the situation or the location of the tear, because according to the, let's say, the curve and anatomy of the internal carotid artery, maybe the pipeline cannot, or the stenting cannot be done. This is what happened. We have had 2 cases of sacrifice of ICA. I present one of them, and in these 2 cases that were years ago, before the modern era of pipeline, but at that time we couldn't place any stent of satisfactory pipeline. It depends on the segment. If you have damage, probably for the first example, that was 2014, at the P2 segment of the internal carotid artery, probably nowadays this artery could have been preserved without sacrificing, but it was 7 years ago.
So actually, you made a very good point with regard to being careful about radiation therapy, previous radiation therapy, or previous surgical exercise resulting in fibrosis, and that exposes the carotid artery to a greater proportion of injuries. So, and like chordoma, who has already been radiated, which you showed after 14 years, came back. And I think when you have this kind of a situation, you have to be doubly guarded. And it's possible that you should use all the possible devices, navigation, of course, but at the same time, Doppler during the operation,
Right.
so that you know where you are, because that's a very important way to detect your position, especially in radiated cases.
Yes, you are absolutely right. We use very frequently, that is very easy, the probe for ultrasonography, but as you mentioned, but you know, sometimes all these problems came unexpectedly. One of the other case we had to sacrifice the artery was with a small knife trying to cut some dura in another acromegaly that, as you know, have let's say bigger arteries, and we just make some incision in the carotid artery. Sometimes it's because of course mistake, but I mean unexpectedly. And of course, I do agree regarding the use of ultrasonography and Doppler. I mean, of course, I do agree and I do warn regarding the cases that very much increase the risk. You mentioned that, Keki, cases in which the carotid is involved in 2 or more segments with previous radiotherapy, with previous surgery. This is the highest risk. Chondrosarcoma is a very good example for that. Chondrosarcoma, usually you don't have to reoperate chondrosarcoma because respond very well to radiotherapy. But I mean lesion at the petrous apex that very easily involve the 2 curves, the 2 first curves of carotid artery, 3 segment, you can have a big problem.
So in such a case, would you prepare your endovascular team or keep a catheter inside the carotid artery already whilst you're operating, so that the moment it bleeds, you can use the appropriate stent or flow diverter immediately to stop the bleeding? Would you keep yourself prepared to today, if you have to do a reoperation on a case like that? Would you keep your endovascular team prepared? That's why I said in complications, you have to anticipate.
Yes.
A good surgeon will always expect the problem before it happens.
Yes, thank you very much. This is right. Well, fortunately, our endovascular team is 24 hours on call. Usually, this kind of operation are, let's say, a scheduled surgery. And in the cases we have to take the patient to the angiography room, they were prepared. It was, let's say, 1 p.m. or something like that. And yes, this is very important. And I think that if you have to deal with a case that potentially may lead to, ICA lesion, you have to think about the possibility of that, because if you don't have the endovascular team nearby, you can have a big disaster. And regarding, well, I have to mention that thanks to you, Keki, because first time I collect and I gather all my disasters that I openly and honestly show to you all, my friends. Before that, I wasn't aware of how many things we have to do to prevent that and to treat that. And this is, and it was collecting my cases and reviewing all my mistakes that I learned very much. And I make also, of course, a review of the literature. And I think now, thank you to your webinar, Keki, I am now much more prepared to face those possibilities. Of course, to avoid that. We also do, in some cases, huge glomus jugulare tumor involving carotid artery. Luis Borba has a tremendous experience, very good friend, and I exchanged the cases with him to know his opinion. And in some cases, you have to even place an stent in the internal carotid artery at the neck before attempting the removal of the lesion. So there are many things to be done to prevent such a terrible problems. And of course, endovascular treatment plays a crucial role. Going back to your question, yes, very important to have available the possibility of endovascular treatment.
Okay, thank you very much, Miguel. And I'm sorry that we have stopped you from your entertainment program of your. Thank you so much.
With your permission, I'm just rushing to the venue.
Yes,
Because I'm the master of ceremony, as you can imagine. And if I miss that, I will be headed. I cannot.
our compliments to your and we have thank you very much.
Thank you, Miguel, very much for your contribution, and you are also always supporting our educational activities. Thank you very much.
My pleasure. All the best.
Thank you. We have just 1 minute left for this session for Professor Goto.
Yes.
I'm looking for questions for Professor Goto, and your point about the plexal point is very interesting. Plexal point that you explained. Is it possible to know this intraoperatively during the operation?
Of course, the preoperative tentative occlusion can be checked by MVP and SCP. I didn't perform the transient occlusion before obliterations because I believe the plexus after plexus point in colloidal segment never to branch to the diencephalic branch. That is my previous knowledge. But after these complications, I changed my mind, and before obliterations, of course, that is the colloidal point, colloidal segment. We should check the MEP and SCP before obliterations.
Does anybody else has an opinion on this point? Because it's a very interesting point that Dr. Goto has raised. Either Dr. Caldwell is around, if he has had the experience to talk about this, or Dr. Kono, anyone, any skull-based surgeon? Okay, all right. Yes, of course, your flow dynamic therapy theory was very complicated, but very simple to understand that the longer the tube, the greater is going to be the resistance, and of course, the wider the tube also, lesser the resistance. So that's a principle of physics which you very nicely reminded us. And therefore, when you are putting a drain, you should try to use shorter distances for more
Yes, that
effective
is good
drainage.
point. Yeah.
Yes.
During the operations, I checked the CSF protein concentration.
Yes.
That was only 100. But the 2 days later, his protein level is increased remarkably 700 and keep the 10 days. I don't know this fact during the management. But the patient complained his visual deteriorations. I never imaged such protein concentrations increase the viscosity of the CSF. That was my complications.
So if you are doing a ventriculoperitoneal shunt, let us say, for some patient, as now we have a lot of tuberculous meningitis in India, and I'm sure some other countries in Asia also have this problem. So if you're going to use a shunt, what should be the protein level that you can maximally permit for the use of a shunt? Normally,
I have in this patient, it has no meningitis sign, only increasing the protein level.
yeah.
Without a CSF decreasing, I said sugar decreasing or a cell increasing. Only protein was increased.
So what is the maximum? What is the maximum protein value that you will allow?
Yeah, I don't know, sorry. But that shunt was safely achieved and good flow was obtained.
Okay, okay, okay. Thank you. Thank you. Are there any questions for Dr. Professor Goto?
I think, Kiki, we are fine behind the schedule. Can we move to our next session?
Okay. Yes, yes, yes. Yes. So the first speaker of the next session is Dr. Kono, Professor Kono. He will talk about prevention and management of complications in cerebellopontine angle surgery. We all know Professor Kono's great experience and expertise in this subject, and it is our privilege that he has accepted to speak on this very favorite subject of his. And I always like to listen to his ideas, very clear ideas he has. Professor Kono, I'm
Yes.
looking forward to you. Thank you very much.
Can you hear me?
Yes, very well.
Okay. Can you see this presentation?
Yes, we can.
Can you see it? Okay.
Yes, yes, we can.
Hi, everyone. I'm Professor Kono from Tokyo, Japan. And it's my great honor to be here. And I'll talk about prevention and management of complications in CP young tumor surgery. Thank you for your invitation, Keiki and Nasser, and dear friends of many Egyptian neurosurgeons like this. So now, about COI, there's nothing to disclose. At our skull-based center of Tokyo Medical University Hospital, we perform surgery for CP young tumors 2 or 4 cases per week, totaling about 150 cases per year. My personal experience of surgery for CP young tumor is more than 2,000, including 1,500 vestibular schwannomas. CP young tumor surgery is still thought to be challenging, and prevention and correct management of complications is considered important. I'll talk about vascular events, cerebral swelling, and facial nerve injury in this presentation. This is my complication list in vestibular schwannoma surgery. Facial nerve reconstruction, brainstem infarct, cerebral swelling like this. Firstly, vascular events. We sometimes encounter the cases with small asymptomatic infarct on the routine postoperative diffusion image without any troubles during surgery. And in these cases with peritumoral edema, we sometimes experience venous infarction after surgery. About the management of vascular events, if artery bleeding occurs, we can do bipolar coagulation, preserving patency of the artery, pasting technique using fibrin glue liquid A soaked surgical cotton ball for a small vessel, and reconstruction for a large vessel. If there is some change in MEP and or SEP, we do administration of radical scavengers. About the prevention, preserving all arteries and all veins is ideal, but not easy. Proper embolization for vascular tumor is one of the selectable option. In this case of the light vestibular Schumann, a small one, and intention of hearing preservation, right side, after starting the continuous facial monitoring, opening the internal auditory canal, internal decompression, I'm dissecting the 8th nerve, and we can see the facial nerve here. Arterial bleeding occurred suddenly, like this. And I thought this must be the bleeding from the internal auditory artery. So this is the hearing preservation surgery. So I didn't do electrocoagulate. And I put an fibrin glue liquid A soaked surgical cotton ball, pasting technique. And after continuous suction for 3 or 4 minutes, these surgical cotton balls were pasted on the artery. After that, I took the tumor, and nearly total removal of the tumor was completed. This is the facial nerve here. Pre-operative class B was preserved as class B without any facial nerve palsy. In this case of the right vestibular schwannoma, I noticed the ICA loop beside the internal auditory canal, but I overlooked the ICA loop inside the internal auditory canal, and I injured it. Right side, internal decompression. We can see the ICA loop here. After beginning the continuous facial nerve monitoring, I'm opening the ISC, and I'm taking the meatal part of the tumor. Arterial bleeding occurred, and I electrocoagulated it, and arterial bleeding occurred again inside the internal auditory canal. So I realized I damaged the ISC, ICA. And after nearly total removal of the tumor, I'm doing reconstruction of the ICA using 9-0 nylon. So I am checking the patency using ICG. We can see the postoperative infarct, but fortunately, this is an asymptomatic lucky case. Cerebral swelling. Cerebral swelling is the most serious life-threatening complication in CPN tumor surgery. Suspected causes are impairment of venous circulation due to cerebral retraction in the retrosigmoid approach or injury of petrosal veins. About the management, if cerebral swelling occurs, we do ultrasound examination, and if we see the intercerebral hematoma, we will do corticotomy, removal of the hematoma, and do hemostasis. These are the set of 3 procedures for safe postoperative care: foramen magnum decompression, enlarged decompressive craniectomy, plus dural-plasty, and ventricular drainage. And if needed, we add uncapping of the cerebellum. About prevention, for patients with high intracranial pressure of the posterior fossa, frequently seen in young patients with a large tumor, I'm checking and tight posterior fossa, and I'm doing the foramen magnum decompression, and I'm doing first small caudal dural incision and the evacuation of CSF, select cerebellum here. And furthermore, I do minimal cerebral retraction, no, or intermittent retraction, and petrosal veins must be preserved. About the prevention of temporal lobe swelling in the middle cranial fossa approach, this is the usual cavernous sinus, inferior petrosal sinus pattern. And this is the dangerous pattern for middle cranial fossa approach with sphenobasal posterior venous plexus pattern. In this case of the left petroclival meningioma, I selected a combined transpetrosal approach, but venous drainage is so much into the posterior plexus, so it's so-called dangerous pattern. So to preserve venous drainage, I selected a modified anterotranspetrosal approach reported from Keio University group. This is the standard one of the extradural approach, and this is the modification of the subdural and epidural approach. And I did a modified anterotranspetrosal approach plus transmastoid approach, combined transpetrosal approach. I'm cutting the middle fossa dura, and this is the venous system I wanted to preserve. And I'm cutting the posterior half of the dura. And I'm doing Kawas's approach in the extradural area here. And this is the subdural area, and the venous system is here. And cutting the tentorium like this, elevating the tumor. Fifth nerve here, and lastly, we can see the third nerve. The tumor was nearly totally removed without any trouble postoperatively. Lastly, facial nerve injury. About the management of facial nerve injury, in cases we secured both ends of seventh nerve, intraoperative ipsilateral 7/7 reconstruction with a direct or indirect fashion should be performed during surgery. In cases we lost the proximal end of the seventh nerve, 7 and 12 reconstruction or cross-facial nerve grafting should be done later. In this case, in this patient with left vestibular schwannoma, having the facial nerve palsy, House and Berkman grade 3, left side, translabyrinthine approach. Internal decompression first. upper side, lower side, and petrosal vein here. And we can see the brainstem. And I damaged the facial nerve here. So I'm exposing the vertical portion of the facial nerve and sutured with the grafted sural nerve graft. And also I'm sutured the grafted nerve and root excision of the facial nerve at the deep site, anastomosis. And so post-operatively, 1.5 years ago, maybe grade 4, pre-operative grade 3, and something worsened. I damaged here, and I made a new root. About the prevention, real-time monitoring, continuous facial monitoring, and dissection technique under the real-time monitoring. About the real-time monitoring, continuous facial monitoring, we reported this method 10 years ago, and I'm placing an electrode on the root excision of the facial nerve for continuous facial monitoring. In conclusions, surgeries for CP tumors required both prevention and troubleshooting for many kinds of complications. Surgeons who treat this area should know about the correct management of these complications. Young neurosurgeons who want to be a skull-based surgeon are expected to do cadaver dissection training to observe operations and to start skull-based surgeries with well-experienced supervisor. Thank you for your attention.
Thank you, Professor Kono, very much for this very interesting presentation. I'm actually happy to see all these photos with Egyptian friends. And let us proceed to our next speaker. Now I have great pleasure and honor to introduce Professor William Caldwell. Professor William Caldwell, he is a well-known eminent neurosurgeon. He doesn't need any introduction. He is chief at the Department of Neurosurgery, University of Utah, United States of America, president of the World Academy of Neurosurgery, and chief editor of the Neurosurgical Focus. He is a deep friend to all Egyptian and African neurosurgeons. Professor Caldwell, actually, he is doing much efforts in promoting neurosurgery in African continent and all over the world by his contribution to all our meetings and cadaveric skull-based workshops we are organizing in Egypt and Africa. He trained thousands of young neurosurgeons. Professor Caldwell, thank you very much for contribution to this event. Professor Caldwell, would you unmute your mic, please?
So thank you so much for that kind introduction, Professor Algandar. And thank you so much, Keki Terrell, for organizing this session. It's great to see you all. I'd like to talk this morning about a problem that we all face with giant pituitary tumors. And I'd like to acknowledge I don't have any significant disclosures at all. But it's over 110 years since we've been operating on pituitary tumors, originally in Innsbruck, Austria with Schlaffer, and then Cushing, who popularized the technique. And then I was really fortunate because I went to medical school. I grew up in Canada and went to medical school at McGill, and Jules Hardy was one of my mentors and was still very active at the time I was a medical student. And in fact, he and I just more recently wrote a paper on Guillaume's contributions to neurosurgery, who was his mentor. So, and I've been very fortunate to work with some of the giants in pituitary surgery. But I'd like to talk about giant adenomas. They represent about 10% of my own series, and I'll talk about that. But we'll define them as tumors larger than 4 centimeters. And this is a special group of tumors that are associated with specific complications. And I'd like to really give you an examples of the problems that I've had with them. They're 10 to 15% of all pituitary tumors and often have great invasion of the cavernous sinus, suprasellar, intracranial space, and are problematic. And I want to acknowledge the tool, Caldwell, for this slide, because I think this is an appropriate analogy that we can have these giant tumors, but with finesse delivery, because they're soft in most cases, we can remove them through a standard transfenoidal approach and get these types of outcomes. A few of the tricks that I've learned, opening the dura, it's really important to open the dura widely to get out to the carotids bilaterally and expose. The way you get a roof to drop is you remove the floor and the walls, and then the roof will come down. And I use a specific series of techniques to get the tumor out. And one of the things that I do is I remove the floor of the tumor, and then I focus on the lateral and the posterior wall and try to get the arachnoid to come in, and I try to preserve the arachnoid if it's preservable, because the CSF pressure will allow the tumor to help descend, have the tumor descend. And then I don't take the center of the tumor out initially. I use the heft and the weight of the center of the tumor to help bring it down with the CSF pressure. And then we'll use Valsalva maneuvers by the anesthesiologist. And then the big gun is bilateral jugular venous occlusion. And Ed Laws taught me this, and it's really an effective, it's like a super Valsalva maneuver. And you can only do this if you don't have a CSF leak. So I really concentrate on not getting a CSF leak early if I'm doing a transnasal approach to a giant tumor. Now you can do it transphenoidally, you can do it transcranially, and you can also combine them. And I'm going to talk a little bit about what the procedure of choice that I like to use depending on the growth pattern of the tumor. I just want to point out that the extent of resection is low in most cases because there's cavernous sinus invasion. And that really limits the resectability of a lot of the tumors, especially if they have intact cranial nerves. And we'll try to leave the cranial nerves intact when we remove these tumors. Mortality is high, and the reasons for which I will show you. The morbidity in this series of a major review paper that was published about 10 years ago, the morbidity was 14%, but mortality was still 4%. So I've looked at my own personal series, and I've chosen the last 108 cases that's just being published now within the endoscopic era to give you an example of what a contemporary series is like. And I have used a transcranial approach in 1.4% of 2,000 cases, but in almost a third of the giant cases in the last 2,000 cases. But let's look at the last 100 cases, and you can give you an example of the complications that we see. So the average size is over 4 centimeters, as I mentioned, and many of them are hemorrhagic, and they have high NOSP grades. And this is the problem, is that once you get larger tumors, they invade the cavernous sinus, and you get a grade 3 and 4 invasion into the cavernous sinus, according to the NOSP classification. So the complications that I've seen in this last 100 patients with giant adenomas have been the following. I've had SIADH in 2 patients, visual deterioration in 1, intratumoral hemorrhage in 2, and I'll talk about that, CSF leak in 3, which is much higher than my usual CSF leak rate, which is about 1% in my own personal series of pituitary tumors. ICA injury in 1, we were able to just patch it, and then the patient was stented later, and fat graft migration in 1. So, and we've seen, we've got gross total and subtotal resection in 68 of the 100 patients and hormonal replacement in the majority of them. re-resection, radiation in 35%. Let me talk about a few cases. So here's an interesting case, and this is what I'd like to emphasize, that these large tumors are very prone to apoplexy. And apoplexy can be a continuum from infarction to hemorrhage. And this is a dramatic case. It's actually a published case where a patient presented with a diplopia from bilateral 6 nerve palsies. There was no enhancement of the tumor, notice on the scan. I thought it might be a cystic lesion initially, but this was a completely infarcted giant adenoma. You can see the mucosal enhancement around this. This is very characteristic of apoplexy. We always look for sphenoid mucosal enhancement. And we removed this tumor, and his 6 nerve palsies got better. Here's an example of a case that we've never even operated on yet, and the patient has apoplexy, evidence of apoplexy in the past. Look at the subarachnoid space here. It's like a patient who's had a late rupture of an aneurysm, and we're operating on it in delayed fashion. There's hemorrhage all through the subarachnoid space. Now, one of the points that I want to bring up for complication avoidance in these patients is that you've got to try and find the normal pituitary gland. And what we'll do here, we're doing a frontotemporal approach on the right side. You want to be careful, dissect all the tumor off the vascular structures, find the bifurcation, debulk the tumor, and then remove the tumor. And what we'll do here is dissect it off the frontal lobes here, and then dissect it off the anterior cerebral artery, find the contralateral optic nerve, and then go back posteriorly and find the normal pituitary gland, because the normal pituitary gland is pushed up and back in most of these cases. And so I'm debulking the tumor, and we'll just go ahead and complete the dissection. And now what you're doing is I'm going back and I'm finding the interface between the normal pituitary gland and the adenoma. And this is a lot by feel. So the normal pituitary gland is just a nubbin on the posterior aspect of this dissection. And here it is. It looks like a catcher's mitt. We're actually just preserving the normal pituitary gland there. And then we'll go ahead and close. We can also have terrible complications with apoplexy at the time of surgery. Here's a 42-year-old man. This is many years ago now that I operated on this patient. And you can see he has a giant adenoma. Here's his CT. So I chose a transfemoidal approach initially, which I wouldn't do now. And the night after surgery, he had a deterioration. It looks like we were never there. It's hemorrhage within the tumor bed. I couldn't get the tumor to come down. The tumor was very soupy. It was like liquid, and I couldn't tell how much tumor had been removed, but we had a major hemorrhage post-operatively, and he did terribly. So this is a feared complication of partial resection of these tumors. And if I can impart anything during this talk, I just want to warn the young people, you've got to be careful, and you've got to control the mass of the tumor with the initial surgery. It's about 10% of my own series, and it may justify a combination approach to try and get the mass of the tumor out. But it's also changed my paradigm as to when I think I need to do an open approach from the top, a craniotomy, versus a transfemoidal approach. So the classical indications for transcranial approaches are the following, but I would like to just talk about paracellular extension and also cranial neuropathy. So here's another case. And what would you do with this case? This is a 57-year-old woman, cognitive decline. She comes in with hydrocephalus. The residents put an external ventricular drain in her, and she's got this giant adenoma. Now, 20 years ago or 15 years ago, I did transfemoidal surgery on these patients initially, and you saw the last complication that I showed you. I've changed my practice, and I'll show you. I did a transfemoidal approach on this. So this was a non-functional tumor. And no matter what I did, we used the angled endoscopes, the longest instruments that we couldn't get the top to drop. And I took her back the next day and I did a transcranial approach. and remove the rest of the tumor. So I was thinking, you know, if we're going to do two approaches to this patient, could we do everything through one approach? And so now I've changed my paradigm. And so when we have a tumor like this, a giant tumor that I do not believe that will be able to be removed through a transfemoidal approach, I'll choose a transcranial approach to come down the axis of the tumor and then remove the tumor completely. And you can do this transcranially. I just want to emphasize that you can come in and you pick your approach from the top. And here we came in transcortically, and you can remove the tumor within the cella as well. And here we preserve the pituitary gland. So this is what's changed where my paradigm has changed over the last decade to 15 years, is that I'll choose an approach to control the mass of the tumor, and I won't try a transfemoidal approach if I don't believe that I can control the major mass of the tumor with a transfemoidal approach. This is another complication that I had. This is a woman who had radiation for a non-functional tumor many years ago. They deemed that she couldn't have any more radiation. The tumor's in the cavernous sinus mostly, and it's in the temporal fossa. And so we'll pick a transcavernous approach to remove this. She's got a new 6th nerve palsy. And in my hands, I believe that I can do a better job from above. Notice that the tumor's in the cella as well. It's in the cella and in the cavernous sinus. And so we'll do a transcavernous approach here, a la Dolink and Hakuba, lift up the temporal dura, the lateral wall of the cavernous sinus, find our opening. Here we found it through Parkinson's triangle between B1 and 4 within the tumor itself. You'll see we'll go ahead and debulk the tumor through this window. And it's like operating on an acoustic tumor. We'll debulk the center. And remember that when pituitary tumors grow, they push the nerves laterally. The only nerve that I'm looking for here is 6, because I know that that's going to traverse the tumor. And you'll see what happens. We remove this, and the 6th nerve is dangling in the breeze. Okay? So now, the beauty of this, and just like in Dr. Hono's lecture previously, if you were doing an open approach, we can do a direct anastomosis. And I had enough length here. I picked up the 6th nerve at the Dorellis canal as it came in to the cavernous sinus, freshened up the end, and then we'll perform an end-to-end anastomosis. Remember, 6th nerve and 4th nerve are perfect for this because they innervate only one muscle, and you don't get cross-innervation, and the results are very, very good. So you should always try to repair 6 and 4 if you can, if possible. And I had enough length here, I didn't have to use the interposition graft. So here's her post-op scan, and you can see we've left a little bit of fat in the cavernous sinus. And her 6th nerve improved over about 6 months. So these giant tumors, they form cysts around them. We don't really know why. It's probably trapped CSF, according to MRI characteristics, but it facilitates the dissection and can help you. This is another pitfall, and this is another complication I want to talk about, is this whole notion of where the tumor is growing. So once the tumor gets into the cavernous sinus, it can grow in the cavernous sinus and then grow from the cavernous sinus. And it's important to recognize this. And so you can see where the 3rd nerve enters the cavernous sinus. It goes through a cistern, the oculomotor cistern. And you can look for this on the preoperative images. And you can see if the tumor is occupying the oculomotor cistern. So here's a good example in this case. Here's the normal 3rd nerve on the right, on the patient's left side, but the oculomotor cistern is occupied by tumor here on the right side. And this is how the tumors escape above the cavernous sinus in many cases. You need to recognize that for a couple of reasons. So here's a cartoon showing this, is that the tumor grows within the cavernous sinus. NOS4 in this case grows or 3B or 4, and it grows through the oculomotor cistern into the suprasellar region. So it's important to recognize this, because if you'll see this bud of tumor, if you come in from below and you don't open up the arachnoid, you will not see this nubbin of tumor. And this is now surrounding the third nerve, or the third nerve is being draped over it. So it's important to recognize this. So this patient, I operated on the patient transnasally, and here you can see the post-op scan. He was fine initially, and then he developed apoplexy in this bud of tumor and developed a new third nerve palsy. And so I came in and repeat operation, and we opened up this region and took the tumor out to give his third nerve the best chance for recovery. So I don't know how to avoid this complication, but any residual tumor that you leave is a nidus for apoplexy in these giant tumors, and it's a risk. So you can use some tricks. This is one that I've used where we can actually expose the cavernous sinus intraoperatively through a transnasal approach using the endoscope, and then actually extrude some of this tumor. Here's an example. A lot of tumor in the middle fossa, but the dura is still intact here. You see around the tumor. And so you can use intracranial pressure, Valsalva, to help extrude this tumor through the cavernous sinus. You can do this through the inferior aspect lateral to the carotid, and in between the loop of the carotid here, in this region here. You've got to be careful of the sixth nerve, but if you do this carefully, you can extrude tumor in many of these cases if the tumor is soft. So finally, I just want to talk about the last complication that I want to talk about is really this issue of residual and what to do with residual. So the controversy is, do we radiate now or do we wait? And we don't have good class 1 or 2 evidence demonstrating what the best thing to do is. I've used both approaches where I've radiated early, and certainly for functional tumors, we'll radiate them. But if they're non-functional, I usually wait, because I have had many delayed complications of cranial nerve palsies with radiation of the cavernous sinus. And we're just writing up a series between meningiomas and pituitary tumors. I've dealt with this a lot over my career. So radiosurgery of the cavernous sinus is associated with delayed cranial nerve palsies, and we need to remember that. And so I like to see the tumor grow before I commit them to radiation. So in conclusion, giant pituitary tumors are still a treacherous problem. Mortality has improved. Complete resection is not possible in most cases. You need to control the mass to avoid apoplexy. And you need to choose your approach to do this at the first session so that you don't avoid the complication that I showed you where the patient deteriorated in the middle of the night after surgery. Try to identify the normal pituitary gland and preserve it. Look at the MRI. See if you can see where the pituitary gland has been displaced by the tumor, and try to target that and make sure you try to preserve it. And multimodal treatment is necessary in most cases. For my giant series, this is the number of different approaches that I've used. Obviously transsphenoidal, and if they're the classic ones where the tumor is an egg shape and the diaphragm is preserved, those are easy to be removed by the transsphenoidal approach. But when you develop the snowman appearance or the multilobulated appearance, then a transcranial approach is going to likely be necessary. And these are the transcranial approaches that I've used: terional, transbasal, transcortical, and transcallosal. And then finally, I just want to talk about the vascular injury. I know Miguel alluded to this morning already, but acromegalics have large arteries. Initially, a German group had said that the arteries were closer together. I think the real issue is that the arteries are enlarged in these patients, and it can narrow the intercarotid distance, which narrows your operative corridor when you operate on these patients. Here's a little growth hormone secreting tumor. Look at the size of this artery on the left side. You get fusiform dilatation of the artery adjacent to the growth hormone secreting tumor. We did a study where we looked at this. So you've got one side that's normal here, one side that's very, very dilated. And why is that? So we looked at this. We looked at segments of the carotid in a series of patients with acromegaly. So you've got a non-secreting adenoma with normal carotids, but you go to growth hormone secreting adenoma, which is a small tumor here, but with very large carotids, which really gives you a much more narrow corridor. So you've got to be careful. And when we looked at this, the acromegaly group had 1 millimeter larger arteries in general, and they can develop fusiform dilatation greater than 5 millimeters in 30% of patients. So the cavernous carotid can be significantly dilated, potentially increasing the risk of injury during surgery, and 50% of the patients at least greater than 5 millimeters. And then I like to talk about operating on giants. This is a case that I did in Eastern Europe some years ago. This man was 8.5 feet tall. And the problem that, the problem that you have with these patients is that your classic instruments don't work. So we used an endoscope here, but we needed to get urology and general surgery instruments to reach this tumor because of the size and the depth of the tumor in this particular case. So these acromegalics are difficult in many ways with the carotids, with the soft tissue. Yep. And I thank you very much.
Thank you very much, Professor William Caldwell. Great presentation as usual. I think we have to proceed to our next speaker because we are a little bit far behind our schedule. And then we'll have discussion for 10 minutes at the end of the second session, which will be moderated by my friend, Professor Kiki Torel. Now I am honored and I have the great pleasure to introduce Professor Henry Schroeder. He is chairman at the Department of Neurosurgery, University of Medicine, Greifswald, Germany. Professor Schroeder is also a friend to all Egyptian neurosurgeons. He's doing much effort in educating Egyptian and African young neurosurgeons, as well as young neurosurgeons all over the world in the field of neuroendoscopy. I would like also to mention something important, that we have a memorandum of understanding between Greifswald University and Cairo University, to which I am affiliated. And through this memorandum of understanding, we have a very important collaboration since years, and we have fellows already in the center of Professor Henry Schroeder under training in Germany. Thank you, Henry, for contribution to this event.
Dear Nasser, dear Kiki, thank you very much for this kind introduction. It's a great pleasure to contribute to your webinar. And I hope I will come to Egypt soon when we have now an improvement of our COVID situation. And in Germany, the numbers are really going down. But we are afraid of Kiki's variant, the Delta variant, which comes now more and more to Germany. Yeah, but I look forward that we have really a hands-on course this year in Greifswald. I hope so, for the Egyptian students with our exchange project. So my topic is avoidance or management of complication in endoscopic skull-base surgery. No disclosures now. You know, the endoscopic endonasal surgery has now really a boom. It's used a lot. There are very good indications. There are a lot of advantages compared to transcranial approaches, but there are, of course, limitations, and we should know that the transcranial approaches and the endonasal approaches have their place in neurosurgery. And if you look to that region, you see there are a lot of delicate neurovascular structures, and these are, of course, at risk, especially, of course, the carotid artery, but also a lot of nerves are in our area of approach, and we have to be very careful. So avoidance of complications begins already when you plan your approach. You have to look very carefully at the imaging. So we need always in our cases a CT scan to look to the bony anatomy. That is very important. And of course, we have to look at the lesion itself to make sure it is a really good choice for endonasal surgery, or would it better to make a transcranial surgery. And then, of course, we have MR imaging. You want to see how is the relation to the carotid artery, what is the relation to the nerves, to the optic nerve, pituitary stalk, and so on. So that is very important that we plan individually for that patient the approach. We frequently use CT angio for navigation if we have lesions which destroy the skull base, especially in chordomas, chondrosarcomas. to have a good understanding of the course of the carotid. You see here, the petrous segment is displaced by the tumor. And that, of course, is very important to know. So navigation is very helpful if you have not a standard pituitary case where you have a better orientation, in my opinion, according to the landmarks, especially if you have a very pneumatized sphenoid sinus. Positioning of the patient is also very important, especially in obese patients. So we always give the back 30 degrees up. We turn the head to the patient and we tilt it a little bit to the contralateral side. So I have a very convenient position for my surgery. I had already low back disc surgery, so I need to be very careful with my back. Epinephrine, also very important that you have a good visualization and you have not a blurred vision because of bloody mucosa. And last but not least, of course, we need a good image quality. So my preferred camera is still HD. I like it more than the 4K camera so far. It gives really a very good view, and especially the wide angle of view is very important. So we have not only the look what we have with a microscope when we see just the cellar. Keki, what you said? And we can see here the clinoidal carotid. We see the optic nerve, lateral OCR. So you have a very good orientation, and because you see the relation of these structures to each other, you are very safe in your dissection because you know where it is. And then when we open the dura, you see the small artery and veins. So HD is a must, in my opinion. 4 hands are also very important because the surgeon needs to have 2 hands for bimanual dissection. I think bimanual dissection, if you have intradural dissection, is very important. It's the same like you have in the transcranial surgery. So you should not simply pull on the tumor, but you should dissect the arachnoid, which is the most important step in the dissection of intradural lesions. Microdoppler is very important. Just yesterday, we had an acromegaly patient, and as Bill has said, there was really a huge carotid. Initially, it looks to me it must be tumor, but this was the carotid. And when you have a Doppler, you can make this sure before you make an unintended cut into the carotid. Of course, skull-base reconstruction is very important. If you look at the lesion, you have to plan. If you see it's an intradural lesion, or probably you will have a big hole in the diaphragm, we prepare, of course, a nasoseptal flap. But if you have no CSF flow, we just put a little bit gel form it. Sometimes we use bone or a resorbable plate called PDS. If you have a minor CSF flow, usually we have Duragene, fibrin glue, and then we make a reconstruction of the cellar floor with a resorbable plate. And in the major CSF flow, of course, we use a nasoseptal flap and fat. Then we avoid any resorbable artificial things. I just want to show you this resorbable plate. I think it's a quite good indication if you have not enough bone. You see we place it epidurally below the margin of the cellar bone opening. And this is a technique. So we put some gel foam in the resection cavity, and then we have this polydioxanone thin foil, which was originally used for orbital roof reconstruction or orbital bottom reconstruction by the maxillofacial surgeons, and we place it in the epidural space. And this is a buttress. I think it's very important. Sometimes we have no CSF leak. We put just a little Duragene or we put fat, and then the patient is coughing or sneezing, and then the diaphragm ruptures. And if you have this rigid reconstruction of the bony floor, you can avoid this late complications with CSF leakage. Nasoseptal flap, of course, very important. This should be raised in all cases when you have an intradural lesion. And what I strongly recommend is also to make this reverse flap, which is introduced by Carotid. Rick Carotid has showed that to us, and we use it now very frequently, and you can put it on the other side where you took the nasoseptal flap from. So there's not too much denuded septum, and the recovery is much better. You have less discomfort, less discharge from the nose, and also less crusting. So it's really strongly recommended. And usually you see a good enhancement of the flap, and this shows you there's a good perfusion. And with the nasoseptal flap, you can decrease the CSF leak under 5%. Some people state it's under 1%, but in my hands, it's still not working with 1%. So what are complications, what we face with the endonasal? Of course, hemorrhage may occur. If you open here the sphenoid sinus with a kerosene, of course, here is the origin of the posterior nasal arteries from the sphenopalatine artery, and you get a hemorrhage here. If you get a hemorrhage, it's not a problem. You can use simply a monopolar suction and you can occlude this vessel. It's very important that you have a good coagulation of this area, because sometimes you get delayed hemorrhage when the patient is already at home, and then he can have severe nose bleeding, and this can really bring a problem, because sometimes it's really a strong hemorrhage which can relate or can lead to a shock of the patient. This is another case. We had tuberculum cellular I coagulate the superior intercavernous sinus, and then there was a brisk bleeding. Although I had the patient with the body up, initially I thought, oh shit, this is a carotid, because there was so much pressure in this small sinus. But you see, it's a dark blood, it's just sinus, and the hemostasis is very easy simply by injecting flow seal, and you can continue. But you see the carotids are very narrow, and you have to be very careful. In my series, I had one case of a carotid artery injury. Fortunately, here by cutting, there was a recurrent case, and I want to go very close to the carotid, and I was a little bit too close, but you see it's very clear an arterial hemorrhage, but very small cut. And I was lucky, I just used bipolar coagulation to close this small tear or cut in the carotid. Careful coagulation, then I flipped this dura over the carotid leak, and I just coagulated and sealed it together. And then I continue with my surgery to remove the tumor. And of course, what you have to do is you have to do repeated CT angio to rule out that you get a pseudoaneurysm. But you see here in this area where I had the laceration, there was no pseudoaneurysm and everything was okay. So I was lucky, but it was not a pulling. If you take a grasper and you grasp the wall and you pull, of course you cannot do that. Then you have to pack the sinus and go to the interventionalist. CSF leak is still the major problem. I had one case where I really cut the whole diaphragm, and this was a tumor. You see an intracellular, supracellular tumor, and I cut here where I usually cut the cellular dura. But this was anomaly because the diaphragm is inverting very low. So insertion of the diaphragm is here, and I had a severe CSF leakage. I was surprised, but I cannot expect this from the imaging. So I removed the tumor. And then you see the whole diaphragm comes down. So it was a whole cut here all the way through the diaphragm. Of course, that is not nice. So I remove the tumor now. It was a good gross total resection. And then you see this is the whole, I cut the whole diaphragm from the frontal dura. So then I thought it is not enough to take glue or so. So I put stitches to close it. So I have not this elegant self-tying stitch from Medtronic. So I had to use my stitches, what I have on the table. And I placed 3 of these to attach the diaphragm back to the dura. So this is the dura, which comes from the frontal skull base, and the insertion of the diaphragm is much lower than expected. But I think it's very difficult to expect that it's so deep, because in most cases we cut here the dura. And if you have a previous image and you see it, you know where it is. But if you have just one image of this large tumor which pushes the diaphragm up, it's difficult to expect. So we make the stitches, and I put some fat in. And then finally, I think it's very important that you buttress this. You have a buttress with something. You can use bone, but I use frequently this resorbable plate. And this gives a kind of bony reconstruction. So if the patient is raising his intracranial pressure, you have some protection. And this is 1 day after surgery. You see a lot of fat is in. Then after 3 months, you see a resorption of the fat. And then after 1 year, it looks pretty good. And why was this complication? Because you think this is the diaphragma pushed up, but here the diaphragma insertion is originally here, and then you have a duplication of the dura. So the diaphragma goes up, but here's already the frontal dura, and I simply cut through this. And that's why we had this problem. So brain abscess can also happen. This was a lady, she had an ophthalmic roof meningioma. She had the transcranial surgery at another institution. She came to us and we removed this endonasally. And although our flap was not too bad and there was no CSF leak, she developed this brain abscess, which required a long time of antibiotic treatment. And this is finally the result after a few months. And also vasospasm can be a problem. Bill showed already some complications with the large tumors. We had one case with this huge tumor in a young lady. I thought it is a craniopharyngioma. So we made an endonasal surgery. When we opened it, it became clear it is a cystic pituitary adenoma. And because of this cystic lesion, if you open it, there's an immediate decrease in size. And this obviously put a lot of tension to the surrounding structures. If this sac is collapsing and has some connection to small veins, to the brain or the arachnoid, this may cause some unexpected hemorrhage, what you don't see. But you see here, it's clearly an adenoma. So we resect the tumor in the usual fashion. See all adenoma tissue. Here's already the diaphragma coming down. And I think this immediate collapse of the tumor gives a lot of stress to the structures of surrounding tissue. You see, this is a normal gland here. You see the typical vasculature at the dorsal part and cranial part of the lesion. So we resect it. You see, this is a normal gland. This is all normal gland. Then the tumor is resected. This is the image. She was doing fine, no problem. And then 5 days later, she got a weakness in the arm. So I was at a conference and my guys made a CT scan. They don't see bleeding and they know it's okay, observing her. Then they called me and said, you must have to make immediate MRI and a perfusion study. And you see, this is a hemorrhage, which is visible now after 5 days. And you see here in the anterior cerebral artery complex, there is a hypoperfusion. And then they went to the angio and you see severe vasospasm in the internal carotid and also in the anterior cerebral artery in the A1 segment. And then they made an angioplasty. Unfortunately, she recovered. This is the final result. So she's doing good and has no problems. But this should be taken into considerations. If you have some hemorrhage, vasospasm may occur. And what Bill also mentioned already is that you have an apoplexy in residual tumor. You see, this is also Dumper-Schuh tumor. So we resect all this tumor, but the tumor here in the third ventricle that came not down. And then we sent the guy to the ICU, and then in the night he deteriorated in consciousness, and you see he developed obstructive hydrocephalus because of the hemorrhage of this part in the third ventricle. And then we came in with our ventriculoscope and we removed the tumor with the ventriculoscope from the third ventricle. But it's very important when I have now a case and I know that the tumor is not coming down, when I make an endonasal surgery, I would make immediate resection via transcranial approach, or here we had 3 cases where we simply made an endoscopic endonasal approach with our ventriculoscope. Or you select, like Bill advocated, from the beginning and transcranial approach. See, this is a final result. This is an old guy, over 80 years, but he is doing fine now. And of course, he has pituitary, he's panhypopit, but has no DI. So the major complication in my series are CSF leakage. Usually it is in chordomas and in craniopharyngiomas. I have only one carotid artery injury, 2% meningitis and 2% nasal hemorrhage delayed. If you look to the literature, there is a report about 800 patients. It was the initial Pittsburgh experience. They had 16% CSF leakage in their patients. but only 1% of intracranial infection. Although we go through the nose, the rate of meningitis or intracranial infection is really low. In more recent studies, the CSF leakage rate is much better. This is a very nice paper from Dan Kelly. He has just 9 postoperative cases, just 1.6%. This is really amazing, and only 1% meningitis. But I think in the future, with the improvement of our reconstructions techniques, the CSF rate will really go down. And he also stresses that the buttress is very important. And I see this also with our resorbable plate. Since we have a buttress, the CSF leakage rate is much lesser. Then about vascular cases, usually the rate of carotid artery injury is less than 1%, but it's, as stated in this paper also from the Pittsburgh group, is ICA injury is underreported. It's the same like with basal artery injury in ETV. Most doctors do not report the complications, and that's why I think the rate is much higher. And this is the same here in ICA injury in endonasal surgery. So my conclusion is, you have a proper preparation prior to surgery. Look at the MRI, understand the anatomy. You have to study the MRI and CT scan very carefully. Navigation is helpful when you have no landmarks. Use of Doppler is strongly advocated. And you have to have a plan B in case of complications. And of course, care post-skull-base reconstruction is mandatory, and you should have a very good post-op care. I hope we can invite you to our Baltic Sea endoscopy course this year. Let's see, we are discussing with our university, but I hope we will do it. Thank you for your attention again, Nasser and Keki. Thank you for the kind invitation.
Thank you very much for this great presentation. And now I leave the mic for Professor Kiki Turel. In order to open discussion, we have discussion, and we have many questions over the panel. Kiki, are you ready?
Thank you. Yes, thank you very much. We have, yeah.
Keki, you're muted.
Thank you. Thank you. So we'll take one presentation at a time. Dr. Kono's lecture, of course, I thoroughly enjoyed because CP angle also is my favorite area. But, and you talked about the important point of venous infarction, because I think that is really a terrible complication which can sometimes result in mortality. And I think amongst all the CP angle problems, venous infarct is the most difficult and treacherous. And as you said, there is a way to prevent by reading your MRI before, and you know the extent of edema in the cerebellum and the brainstem because of venous pressure. What is the position that you use normally? Are you using a semi-sitting or always lateral?
No, in Japan, semi-sitting position is not allowed from the anesthesiologist hate this position. So our setting is park bench lateral position.
Yes. So yeah, just put this up, please. So on the panel we have no questions for Dr. Kono. But there was one question on cerebellar swelling, on cerebellar capping. There was one question on cerebellar capping. What do you mean by uncapping? I believe it means partial cerebellar removal.
Yeah. Cerebellar lobectomy. Outside, lateral side, one third.
Yes.
Keki, can I just make a comment about the venous injury?
Yes, of course.
Yeah, and I think Professor Kono was involved with this, but we do have a couple of survey studies that just came out from the World Academy on the risk of venous injury. And I think it's probably underreported. And it's clear that the more experienced the surgeons were, the more they worried about venous injury. And because we've all experienced it. And I think it would be worthwhile for the younger people to review some of those, The problem that I see is that the venous anatomy is unpredictable, as Professor Kono showed, and you never know whether you can get away with taking a particular vein. And it's especially problematic in my mind in these basal meningiomas where you've got some meningioma blocking some of the venous outflow through the cavernous sinus, the inferior petrosal sinus. They may be more dependent on the petrosal vein in those cases. And so I've had a case where I had a terrible complication with a petrosal venous infarct all through the thalamus and the brainstem on a patient that looked like very innocuous venous anatomy. So it's unpredictable. And I think we need to have a deep respect for the veins. And I think the experienced surgeons understand that very well.
In our last webinars, we had a lot of discussion on venous injury and in the CP angle in microvascular decompression, other such cases, not to sacrifice the petrosal vein at any cost. And people are still not very, they are not taken this message very clearly. And I see time and again the petrosal vein, the moment it comes in the way of the operation, it is coagulated and cut as if. And many a time they get away with it. And that is the bad part of it. That when surgeons get away by sacrificing the petrosal vein, they think there's nothing wrong in sacrificing it every time. But you have one mortality in a benign case like that, and you will never forgive yourself for doing that. So venous respect for venous anatomy is very important. And I think this is the most important message that we have had from Professor Kono.
I completely agree. With the micro decompression, I had also a small vein. It was not the petrosal, but it was a vein going to the Meckel's cave and then in the superior petrous sinus. And I thought it's a small vein. I coagulated and then I had a severe swelling. And that is pretty clear. The anatomy is unpredictable because it's so variable. And I only coagulate a vein, a microvascular decompression, when I see there's collateral outflow of this vein. So sometimes you have a vein, it comes up, and then one branch goes to the Meckel's cave and one goes to the superior petrosal sinus where the usual cause of the vein is. But I completely agree, you should not take it. I was taught by a professor, you can always take the superior petrosal vein, nothing will happen, but this is not true.
No, actually, I have seen Peter Janetta operate, and he also, late Peter Janetta, he also never believed in really taking great care of the petrosal vein, and he took it away very, and I think that was bad instruction for the present generation. And I think today we have to say it very loudly and clearly that no vein must be coagulated, however small, however innocuous looking it may be. You never know what happens. Yeah, so the next, thank you, Professor Kono.
Kiki, I can find the question for Kono. I don't know if you already asked it.
Yes.
What do you mean by uncapping of the cerebellum?
Yes, we answered it.
Did you answer? Okay.
Yes,
thank you.
It means removal of the cerebellum, partial.
Okay.
Yeah. Bill, your paper and your cases was really very exciting. Thank you very much. I know you talked about Csf Leak, and also later on, Henry also talked about it. When I'm doing my transsphenoidal, I have had a habit of putting a lumbar drain for many years. And my general experience has been that the moment you put a lumbar drain, your diaphragm remains way up. It doesn't come down. And that is one sure way of avoiding a CSF leak. I know that most people are not using the lumbar drain at all. But honestly, this is my experience, and I have never had a CSF leak ever since, for so many years, since the time that I have been using a lumbar drain. I don't know whether you agree with me or you do not agree. What is your opinion? What is your take?
So, I used to use lumbar drain initially when I started doing, but I like to have the pressure head of the CSF help to push the tumor down. Yes. And so but if you do it very carefully and you remove the tumor laterally in the gutters, and then you find that arachnoid as it folds down in the back, I focus on the back and just take away the tumor and watch the arachnoid herniate down. I try to preserve it. That way I can have the advantage of using the CSF Valsalva or jugular venous compression to help pull the tumor down. And so I think that you can, if you put the lumbar drain in, it reduces CSF leak, but it also doesn't allow you to use that to help bring the tumor down. And the big problem with these cases is trying to get the roof to come down, you know.
But has your Valsalva ever produced a CSF leak?
Yeah, no, I mean, we're very careful. If we have a lot of arachnoid herniating in the field, which you can in those tumors, as you know, after you remove it, it's like an inverted uterus coming down. We protect that usually with fat or nasoseptal flap, either way, to protect it, because I'm worried that the patient's going to sneeze or fall and have a CSF leak.
You talked about not leaving behind any tumor for fear of this apoplexy or sudden tumor swelling. And we have seen this and everyone has been talking about it. Is it only applicable to giant tumors or even for small tumors?
Yeah, no, it can happen in small tumors as well. We actually published a series of pituitary apoplexy and microadenomas we had. You know, so it happens in these tumors. They have apoplexy. It's just that it's much more dangerous with the big tumors, I think, because they bleed up into the head, like Henry showed. They bleed up into the third ventricle, like the case I showed. And then you'd get hydrocephalus and the patient has acute deterioration and can die, you know.
So if you have to leave behind a residual tumor, obviously you will be extremely careful in following it up. So do you have a kind of a recipe for that? If you have to leave behind some tumor, what are your guidelines?
So I would, if I decide that I'm not going to do another procedure, like come in from another approach to get it, and we're just going to watch the residual, then I'll get a scan the night after surgery to make sure that the patient's not developing apoplexy into that residual component. I think that's probably a few hours after surgery, and watch it very carefully. Yeah.
And how often? I mean, would they not bleed or apoplex after 2 days or 3 days?
Less likely. They can, as I showed you in that one case that when I opened up the dura, the arachnoid was like a previous subarachnoid hemorrhage patient. So they're prone to bleeding, but I think the catastrophic hemorrhage that I've seen and the complications that I've had have occurred early on, Keki. They've occurred the night after surgery.
Yeah, I agree. Same with our cases. In the night after surgery.
Yeah.
The other problem is of CSF leak, and I've also frequently seen when the leak occurs, people put in a lumbar drain and they try to temporize. I'm talking about immediate post-op CSF leak. And they try diamox and try some other conservative methods. And my feeling is that if there is a leak, then it has to be addressed immediately. If you have not been able to stop it during the operation, you need to go in again the same day or the same night and stop it, because you never know if the patient will survive until the next day. What is your take on that?
Yeah, so basically the protocol that we use is if we have a CSF leak post-op, and what we'll do is we'll get a scan and we'll see if the fat graft is shifted, or if we used a nasoseptal flap, if it's still there. Sometimes the nasoseptal flap bows a little bit down, and then we'll put a lumbar drain in those patients if it's not displaced. If it's displaced, I take them right back and we do it properly. We put a lumbar drain in as well. If it's not displaced and the fat graft is still there, or the nasoseptal flap is still there, but it's just pushed down a little bit, we'll actually try a lumbar drain for a couple of days first. Okay. I'd like to hear what Henry does.
Yes,
That's
Henry.
The same. If I have a good reconstruction done during my surgery, and this is confirmed by the MRI, we just place a lumbar drain. If you see that your reconstruction is dislocated, or you did not do any reconstruction because you thought the diaphragm is okay, then of course we go in and make a reconstruction.
Yes. Let me see if there are any questions on the box. Yeah, there was a question. What was your method of angioplasty in carotid vasospasm?
Yes, it's the same like subarachnoid hemorrhage. This is the same. It's a subarachnoid hemorrhage occurring because this big cystic thing collapsed immediately, and then a small vessel was ruptured with what attached to the diaphragm. And you could not see it during the surgery. There was no active bleeding during the surgery. And then, of course, a angioplasty in our hands is the best what you can do.
Kiki, I can see question for Henry. what major worry is injury to carotid artery, how to manage if it occurs?
As I said, if it's a small cut like I had, then I would try to close it. So it was just spike coagulation, but you have seen it was just less than a millimeter cut. Then you can deal with it. You can also put some muscle on it, compress it. That is the way how we deal with carotid artery injury. For example, if you have it in transcranial surgery, a piece of muscle, I think, is the best what you can do. Then you put some fibrin glue and a patty. And then, of course, you have to make angiography. If you have a severe hemorrhage with a grasper, then I think you have no chance. You have to pack everything, and then you go to the angio suite. And hopefully your interventionalist can solve the problem with a covered stent or with occlusion. Sometimes you have to occlude the carotid.
Okay. Another question, you presented a patient complicated by brain abscess. Did you treat this patient by antibiotics only or by surgical?
We make surgery to release the pus come out, and then we initiated antibiotic treatment after we had the culture.
Okay. Actually, we have many questions over the panel, Kiki, many questions.
Yeah, so Henry, if you're coagulating directly, what would be the tip of your bipolar forceps?
It's 1 millimeter.
Yeah, it's not a small, it's 1 millimeter is quite a good size. Yeah,
no, it should not be very sharp. If it's
sure, exactly. That's what I want to say.
You have a larger hole than before.
Yes, yeah, exactly. This is a very important point because you can make the bleeding much worse if you use a sharp pointer, and therefore 1 millimeter is an optimal. Yes.
And then another thing, what was very positive in my case was that it was not immediate the wall, but around it was still the dura and the scar tissue. So it was not just the wall of the carotid. I think if it's just the wall of the carotid, maybe it would not work like this way, and you have to take some muscle. But there was scar tissue around, and I cut first through the scar tissue, and then I was on the wall of the carotid. That's why I could shrink it together.
Stop it.
If it's just the carotid, I'm not sure that it will work. Maybe you get a larger hole, and then it's better you put some muscle on it.
Yes.
Or I would call Bill, he should make an emergency bypass.
Yes. So you said, Nasser, there were some more questions. Are there any more?
Yes, I think I have many questions. I can see after tear of the internal carotid artery, can we take control of the carotid artery in the neck to avoid the hypotension, then do craniotomy for repair of the tear?
No, I think if you have a local problem, you can try to block it, and then you expose the carotid in the clival segment, and then you may place a clip. But of course, if there is disaster hemorrhage, which is not controlled, you cannot see anything, and you have just to pack it. If it's a small hole, you can put a muscle, a patty, compress it, and then you drill, and then you place a clip. I think it makes no sense to go to the neck, in my opinion.
Okay. Are there any imaging characteristics of tumor with respect to consistency, vascular relation, obviating transsphenoidal approach? You're speaking about pre-operative imaging. Can you?
Yeah, sure.
Okay.
Sure. If you see there is tumor, it's a meningioma, it's encasing the carotid, I would never come from the nose, always transcranial.
Okay, Henry. Go ahead, Henry, please.
Yeah, of course, you should look, and if you see the encasement, then anonasal, I think, is not a good idea. If it's just an adenoma, of course, sometimes it's soft, and you can really suck around the carotid. You can even remove the tumor very nicely from the cavernous sinus. It depends from the consistency of the tumor. If the prolactinoma after dopamine agonist therapy, then you know it's very fibrous and will not work. So it depends what kind of lesion it is. Of course, you can predict it on the MRI. Consistency to predict is difficult, in meningiomas or in general in tumors. If they are bright in T2, you hope it's not so fibrous, but it's not always the case. Sometimes you can get a surprise.
Okay, question for Professor William Caldwell. Is there any role for pre-operative embolization in huge vascular pituitary adenomas?
A good question. I have not done that at all. I've actually stopped doing that for meningiomas because we've had some complications, especially in the anterior skull base, with visual complications because of the ethmoidal anastomosis with the ophthalmic artery. But I have not done that. Usually the bleeding is not that, it can be bad, but it's not that catastrophic. So we can usually work through it.
Okay, thank you. I'm looking for any other questions. Actually, you have many questions.
About the resorbable plate, which Bill
Okay.
talked about. And is there any imaging way to see the resorbable plate? Is it visible on the imaging, Bill?
So it was Henry that talked about that, but the one comment that I would make is I used to leave like MedPore and things in there, and we've used titanium mesh and everything. I think the absorbable plate is a great idea because you saw in Henry's imaging that it goes away and there's no artifact on the imaging. And I think that's really important for pituitary tumors to be able to follow residuals and recurrences down the line. And so I do the same thing. I don't leave anything that stays there permanently that can interfere with the imaging down the line. But I'd like Henry to comment on that.
Yes, I agree. And also you can have, if MedPore can cause infections,
Yeah.
what has been reported. So the best thing is autologous material. That is the best. If you have a major leak, I would take fat flap, no artificial things. But if you have just a buttress, you need a buttress. Then we avoid the second incision. We just put Duragene, fibrin glue, and then this polydioxanone, it's the name. That is quite nice for the reconstruction. You have a buttress. And the problem in my case is when we had CSF leakage, 2 days, nothing was there. During the surgery, no indication of CSF leaks. Then they were sneezing or coughing, and then it ruptured. And then with this buttress, you can prevent that.
Another question, did you encounter any cases of carotid cavernous fistula after operation?
No.
Okay, we have another question. The case you presented by combined transpetrosal approach and transmastoid, can we approach it with Kawasi endoscopic assisted microscopic surgery and get the same results?
This is for Dr. Kono, I guess.
Without facial nerve injury?
So amazing, don't do that.
I've never had the experience of endoscopic anterior transpetrosal approach, using microscope.
Okay.
But the endoscope is a very nice addition. If you make your vestibular schwannoma surgery, you have shown so nice video cases. If you have a remnant in the fundus and you don't want to drill too much to avoid opening of the posterior semicircular canal or vestibule, then the 30-degree endoscope is ideal to see that part of the tumor, and you can nicely remove it with a curette. Just try it, Dr. Kono.
Okay. Yeah.
Okay. I think
Okay.
we finished all questions. Anybody raising hands would like to speak? I have seen Najaya Al-Abadi. Najaya, are you here? Najaya? Okay, I think we answered all the questions and it's time to proceed to the next session, which is going to be about complications in spine surgery. Kiki, would you introduce our first speaker, please, Professor Salman Sharif?
Yes, please. Sure. Thank you very much. So thank you very much, Dr. Kono and Bill and Henry. Wonderful, wonderful session. We learned a lot, and we hope now. So we will continue with our program on spine, complications in spine surgery, 3 papers, one on complication avoidance by Salman Sharif, and then complication avoidance in endoscopic spine by Dr. Yadav, and thirdly, complications in minimally invasive spine, non-endoscopic by Mazda.
Let me
So,
also thank
Vice-
professors of the last session, Professor William Caldwell, Professor Henry Schroeder, and Professor Kono for these great presentations and a great discussion. Thank you very much.
So welcome, Salman. Salman is a very, very outstanding spine surgeon of the world. He is, as you can see, president of the World Spinal Column Society, and he is the co-chair of the Spine Committee, along with Mehmet Zileli. And he is also a leading neurosurgeon in Pakistan at the Liaquat National Hospital in Karachi. And of course, a very dear and personal friend, which is the reason why he is here. He's very difficult to get. He's so busy with his own webinars, but he has respected my invitation. And so here we are. Thank you very much, my dear friend Salman. We are eager to listen to you. Thank you.
Thank you, KK. Thank you, Nasser. I think it's really my pleasure to be in another webinar belonging to the KENS and again, WFNS Complication Committee. It's really my pleasure. I think when we talk about complications of spine, obviously three main areas that KK has just focused that three speakers are speaking on. So I'm just going to go through three cases which I dealt with and the problems that had and how we can avoid them. So the 17-year-old boy, underweight, pre-medical student, complained of mid-thoracic pain radiating anteriorly to chest for a year, progressively increasing, aggravated by axial loading and relieved in recurrency. So typical of something blocking the cord. Paresthesias, progressive paraparesis for 15 days and became bedridden for 5 days and developed urinary problems for 2 days prior to seeing me. He had mid-thoracic tenderness, neurologically intact in upper limb, lower limb had power 3/5 with spasticity and hyperreflexia grade 4 and a sensory level of D7 with subtle anesthesia. His investigations actually were within normal range, although despite that, a diagnosis of spinal tuberculosis was made and that was based on clinical judgment. So this was his initial MRI scan that he presented with, and he had this collapse here along with all this gibbous that we can see anteriorly and posteriorly, and he had gone into paraplegia. So this is again the tissue that we're seeing outside and part of the pus going inside causing pressure, and part of the posterior elements were involved as well. So he had this kyphosis. So what we did was we took him to theater, did an open D4 laminectomy, did pedicle screws and a level above and below, and we thought we did the job well. These were our end results at the time of surgery. He was discharged home on anti-tuberculous treatment. Power was 3/5 with reduced spasticity going home. He presented again 10 days after discharge with paraplegia, no power at all for 2 days, grade 4 reflexes. He was incontinent. And what we found was it was worsening of his gibbous despite our hardware being there. And this was his scan showing that the gibbous had worsened and the curvature had worsened as well. And this was the new MRI, which showed that the whole thing had slipped backwards and it was causing severe pressure on the cord. This was the situation at that post-operatively, and you can see what happened in few days' time. So the whole thing has slipped. And the reason you can clearly see that, our screws were lying inside in the tuberculous spine on both ends. So our screws were not steady at all. So we basically extended the construct by one level above and below, and we reduced the kyphotic deformity, did Smith-Peterson osteotomies at multiple levels, did a ligament excisis, and we achieved reduction of the kyphosis. This is the second construct. This was discharged home in paraplegic condition, advised ATTV and aggressive rehab. This was his post-op scan, which showed that the kyphosis had much reduced. The compression was much better, and we advised aggressive rehab and therapy. And he continued with his ATT. So he followed up 4 weeks later. Lower limb motor power had improved to 4/5. He was able to walk with a Zimmer frame. That's typical of majority of the TB patients we see. This was his CT a month ago. And this clearly showed that the screws were holding its own, the curvature had reduced, and he was doing pretty well in this present scenario. So what went wrong? Obviously, patient had energy. There were non-elevated inflammatory markers. The short segment that was done, and the screws were going into a diseased vertebra causing problems. So we did not do a pre-operative CT, which we should have done, and looked at which levels were involved. And we felt that we got a pretty good purchase, which we didn't clearly. So some literature review, obviously we can see that anterior approach indications generally are less than 3-level disease. Vertebral fixation is in affected segments. So if it's more than 2/3 of the normal height, you would intervene anteriorly. But all this has changed, and recently we don't do anterior surgery, and we can do all this from posterior approach. The advantage of anterior surgery is obviously you can get complete debridement, direct access to the lesion, and canal decompression along with the grafting. The big disadvantage is poor deformity correction, limited construct length, and there is a morbidity associated with thoracotomy or retroperitoneal approach. Loss of bone leading to removal of multiple vertebrae would lead to having big cages and big piece of bone in there if you want to replace it. And that's, again, a worry that I have when I'm doing anterior approaches. So I rarely do anterior approaches now. Posterior approaches, paraspinal soft tissue involvement. If it's more than 50% involved in the vertebral body, you can come by a posterior lateral approach. Advantage, obviously, you can have excellent deformity correction even from behind. You can improve construct stability despite not having anterior construct. There is no limit to length of the construct and less morbidity. Obviously, you are going to be debriding the lesion much less, but this is TB, so you really don't need to do much. And there's difficult placement of the anterior construct. Then combined surgery. So you either single or 2-stage, and it has the advantage of best deformity correction if you really want to do that. I rarely do this because really you don't need to do that. So if you see this study, multi-center retrospective case control study, having groups of to achieve fusion, neurological recovery, and pain only, and comparing posterior only versus combined approach, and anterior only had the greatest loss of correction rate. And the reason was obviously you lose all that body when you're operating anteriorly. Posterior only decreases operative time and blood loss, and corrects kyphosis best. So that's what you probably should be doing, because superior kyphotic correction, spinal stability is maintained, and decreased loss of long-term correction rate. So in that particular case, clearly the problem was ours. We did not do a pre-operative CT, how good the quality of the bone was when you put in screws through the disease segment. Another patient who presented to us who had a trauma and then presented to us with these screws and one of the screw going through the canal. He had decompression. This is for a trauma, and this surgery was done in another city, and the patient came over to us. So why and how can we malposition a screw? Why would we do that? So we need to look at, anytime we have a scenario like that, you look at L5 vertebrae here. Ideal medial trajectory is all the way laterally. The reason being that the trajectory is 35 degrees medially. So you always start laterally so you don't cause a problem like that. And you see one side and compare it to the other and make sure that it's not happening on the other side. A single AP image would have sorted this problem in that particular case. Trajectory, if you start laterally, then automatically your medial angulation would be better. On the other hand, if you start medially, then obviously you can cause problems. Remember, good starting point is the most important step in any surgery in which you're using either image intensifier or freehand surgery. Obviously, screw length has to be important here. You can see that what has happened is the screw is loose here. You can see a halo around it, and obviously this screw is not going through where it should be going. And then you do not go bicortical. You do not need that in lumbar because you know there are structures going anteriorly, and you don't want to be causing problems to that. So loose screws, obviously you appreciate the halo, and you have to take it out and readjust it and put it through a right area. So your entry point should be all the way laterally here and not here and here in this case. And obviously we went in medially and caused problems. So you can put in a 7-size screw in that particular area. So common preventive strategies, how you're going to do this. You should know your anatomy. You should feel the anatomy. You should know everything before you're doing this. If you breach a wall, always take an AP fluoroscopy to start afresh where you want to go. If you feel that your screw has gone wrong or into the canal, reposition immediately. Do not leave it for some other person. Do not leave it, because if you leave it, you're going to cause permanent deficits. If you remove it straight away, your chances of causing a deficit are low. You can use neuronavigation or intraoperative CT or robotic, whichever you have, to improve this problem. So why do we navigate this spine? So you see this Gertzman-Robbins classification for malpositioned screws. So the important thing to remember, nerve root injury irritation is reported about 3% of cases in freehand hardware placement. And it's pretty all right to be out by less than 4 millimeter of the medial violation, because there is a safety zone between D10 and L4 that you can come from the side, and even breaching it, you will not cause a neurological problem. But it's important, if you see it, you revise it. Breaches of medial and lateral cortex have shown to reduce pull-out strength as well, and you will cause problems to these patients. So it's important that you understand that fully. So misplacement rate in thoracolumbar spine freehand has been shown to be up to from 2% to 31% in some series. And malpositioning using a 2D fluoroscopy is up to 2 and 22%. So with plain fluoroscopy, it's much a bigger problem. So it's an RCT of 100 well-matched groups using image guidance or otherwise, and it shows a difference between 5% to 13%. Whereas Rajesh Karan showed a IG technique on 2D fluoroscopy difference between 2 to 23%. So it's somewhere there. That's the rate that you're going to be seeing using an image-guided system versus fluoroscopy. If you're experienced, obviously, you're not going to have that much of a problem, but I think it's important that you understand that these are the patients that we are operating on. So positioning of the screws is very important. The last patient that I want to show is a patient who had a laminectomy 6 weeks ago in a peripheral hospital, came with complaint of severe back pain with this MRI with ESR of 125. And the important thing to understand that if you have a patient like this, you do need to investigate and sort this patient out immediately. And this patient may require some kind of fusion if the pain is very severe. And so you clear everything out. And depending on what the problem is, you obviously can do a T-lift here. And putting in screws or a cage is not a problem as long as you debride well and you're aggressive, and patients does not have a frailty index, which is very high. So you have raised inflammatory markers, you could immobilize, and once you're happy that cultures have shown, you can give IV antibiotics. So what is the natural history of infection in a scenario like that? Obviously, you can have a suppurative inflammation and spread. You can have an anterior extension leading to paravertebral discitis, abscess going along your muscles, source muscle on both sides. You can have a posterior extension. You could have an epidural abscess. So important thing to remember, your image intensifier also cause problems, your gown that you're wearing. So if you see about in front of your chest, there are 6% bugs available. Whereas when you come to your abdomen, it's 9%. When you come down below your waist, it's 17%. When you go to your knee, it's about 22% bugs in that area from your gown. So it's important that you're aware that you do not touch below in that area and do not touch that area at all. What about the image intensifier? And this is important to understand for young people, that 16% of the bugs reside on the inside of a properly draped image intensifier, 12% at the area where you're going to be shooting, where 56% outside, and 28 and 20% inside on the same side on image intensifier. So using a combination of povidone solution, 3.3% along with vancomycin powder, we can reduce the infection rate to a dramatic decline. But the downside is you're going to have a lot of serious discharge. So I generally use half of the vancomycin powder than the routine 1 gram, although I wash with the 0.3% povidone in all of my fusion surgeries. Well, CRP, it may be increased after any surgery. If you look at 2 to 3 days, it normalizes in 5 to 14 days. Normal is 1. So peak levels after a microdiscectomy go up to 4.5. Conventional discectomy about 9, anterior fusion about 7, posterior fusion about 13. So these are the normal values you need to be thinking about CRP. What about ESR? For a discectomy, normal peak values is up to 75. For fusion, it's 100. And in case of infection, it's normal plus 2 standard deviation. So it will be going up to 125 to 150. So it's important to understand that you may have a high ESR, but that's just because you've operated on that patient in last 7 to 10 days. So what kind of bugs do we see? Obviously, Staph aureus is the most common with the methicillin resistant in 1 in 20. and Staph aureus 72% of the patient. So there is a low virulent skin organism that can be causing a problem in the long run, which is propionibacterium, and you need to be wary of this, and for anybody who's had instrumentation with infection for a long term. So what are the guidelines? If the spine is not fused, 6 weeks of intravenous antibiotics followed by oral until the fusion of the spine is complete is done. On the other hand, if the spine is fused, you manage this with Staph aureus with 6 weeks of IV antibiotics followed by 6 weeks oral with removal of implant. Whereas in this particular case, when it's not fused, you can leave the implant behind. If any time there is purulent discharge, obviously you need to be thinking otherwise, and you're thinking out of the box. And you may be using drains, vacuum drainage, or irrigation. If you use vacuum drainage, stop irrigation if the cell count goes down to 50 per mil in the drain, and then it usually stops by itself. So these are the 3 cases I wanted to show which are common in spine surgery. And obviously we know prevention is better than cure. So anytime you're doing this, it's important that you see the problems that we can give to our patients and try to ensure that we don't do that. So every time be vigilant, know your anatomy, and understand the concepts of infection and putting in a screw in the wrong place. So I thank you all, and these are some of the pictures from north of Pakistan, and hopefully we'll be able to see you back at some stage. Hopefully you can join us tomorrow and day after in Pulse from the OR of World Spinal Column Society. So it was really my pleasure to be here and talking to you all. Thank you.
Thank you, Salman, very much. Actually, it's a great honor that you contribute to this webinar. Thank you very much. And Kiki, you proceed with the session.
Yes, we will. Thank you. Thank you, Salman. Excellent presentation. Very good learning. We now move to a renowned endoscopic spine surgeon, Professor Yadav. He does magic with his hands for brain and spine endoscopic surgery, and has conducted several courses on endoscopic surgery in his town, which is not a very big town or a well-known place. It's a Jabalpur city in India, but it has become famous because of Dr. Yadav, because of his excellent work in endoscopic spine surgery and brain surgery. And as you can see, he's a chairman of the fellowship program of 1 week, whole 1 week brain and spine endoscopic training he does. And he is the co-editor. He has edited a book called Neuroendoscopic Surgery, which is a excellent readable book, which I also have with me. Dr. Yadav, very soft-spoken, very humble and modest, but an excellent surgeon. I have great regard for him, and I personally invited him to talk about complication avoidance in endoscopic spine surgery. Dr. Yadav, please go ahead.
Thank you, sir. I'm grateful to you and the WFNS webinar committee for giving me this opportunity. I'll be talking about complication avoidance in endoscopic spine surgery. The presentation is based on PubMed search using keyword of spine and endoscopy and the complications. And out of 831 results, relevant references were taken. And this also includes my personal experience of over 1,500 endoscopic spine surgery, which includes lumbar disc, LCS, recurrent disc, intramedullary tumor, intradural extramedullary tumors, anterior and posterior cervical disc surgery, transoral and transcervical endoscopic approach to CVJ, ACM without syringe. The topic is long, so mainly it is discussing the lumbar interlaminar approach. I'll not be covering the transforaminal approach because I don't practice that. Now, regarding the complications, the common complications in spine surgery is dural injury and leading to CSF leak. This is more common in severe compression and when you are dealing with the opposite side compression. I go for unilateral approach for bilateral decompression. So when you decompress on the opposite side, there are little more chances of injury. the wrong use of Carison punch, biting it and taking the dura, and obviously the wrong use of drill also may result into dural injury. Resurgery, as we all know, that there is no ligamentum flavum usually, and it is difficult to separate scar tissue from dura or nerve root. So this can also result in dural injury and CSF leak. So one should identify the risk factor and take the appropriate measures, separate dura from the bone, and keep ligamentum flavum intact until all bony work is done. So I do a bilateral bony decompression first before taking out the ligamentum flavum. Keep patties or bone wax or Abgel whenever it is required. Patties when I use Carison punch, and bone wax or Abgel when drill is being used in between the dura and bone to prevent dural injury. Create a cleavage between the bone and scar and not try to separate dura from the scar. This is another important trick in the surgery. Use 45-degree Carison punch for cranial work and 90-degree for caudal work. One can use dura guard or bone saver to prevent dural injury. Axial drilling can be practiced. Whenever there's a dural tear and the leak, the small leak without root prolapse can be dealt with just simple Abgel or fat or fibrin glue. But if there is a large dural defect with root coming out, in those cases, it is better to have a multi-layer closure using fat, muscles, fascia, and fibrin glue. And one should remove the sufficient CSF to do the repair and reduce the root. Otherwise, patient will continue to have paresthesias. Dural suturing also can be done using endoscopic technique. This is a short video showing the dural repair, but this was not a complication. This is a case of intradural tumor. So the dural repair, endoscopic dural repair is quite possible. The trick is that you have to create a little space by withdrawing your tubular retractor. So withdraw your tubular retractor so that you have sufficient space for rotation of the needle. The other trick is that do not go for any linear movement. It should be the rotation of the needle holder. And by doing this, any dural repair can be possible. If you don't want to go for this, then there are other options also. You can just put in some fat and the patch and use fascia lata. The knot pusher can be used to tie a knot very well, as we do in minimally invasive surgery. And this is what one can achieve in such surgery. The other complication is root injury and the paresthesia, which is more common when the root has been pushed back ventrally by a ventrally placed disc. The root has been pushed posteriorly by ventrally placed disc fragment. As shown here, the root has been pushed. So such cases, if you see in preoperative images, you should be careful because the root is lying posteriorly. In severe stenosis, there is possibility of injury, recurrent cases, foraminal stenosis, retraction of stretched root. So this is also important. I observe many of my junior residents, they try to retract the root which is already stretched. So if you go for this, the patient will continue to have paresthesia. So try to remove, decompress the fragment first around the root which is available, around the available space. And then once the root is lax, then you can retract the root. So remove the disc first without retraction. The other cause of injury is introduction of Carison punch, even though it is 1 millimeter, in very severely compromised canal. Like in this case, there is a thickened ligamentum flavum. So if you try to put in a Carison punch from medial side and try to take out the ligamentum flavum, it may result in the root injury because it is already compromised. Whereas if you come from cranial or caudal line, where there is more space available to remove the ligamentum flavum, you can get away with it. So proper technique will prevent complications. The other complication is wrong level. In endoscopic surgery, it is more commonly seen when there is L4-5 or L5-S1, because if you see this diagram, a little bit of angulation, you can reach L5-S1 or L4-5. So one is that you should always go for when imaging during surgery and confirm the level. And this is more common when you have a lordotic spine during surgery. So if you have such a lordotic spine, then always break the table and make it flat. This will decrease the chances of wrong level, number one. And then in such cases, it will be easier for you to operate, because working at 90 degree, or that is orthogonal, will always better as compared to when you are coming at an angle, because the tissue will come in between the tubular retractor. Excessive angulation of localizer should be avoided. You see the localizer pin, both arms of localizer should overlap with each other. If you see just a one limb, that means you may be at a wrong level. And plus the localizer should be around 90 degree. It should not be angulated too much. If it is angulated too much, then your skin incision will be far away from the level of disc, and this will cause a problem in surgery, or you will go at a wrong level during surgery itself. Excessive angulation of the tubular retractor also. If you see that your tubular retractor during surgery is too much angulated cranially, caudally, or laterally, so be careful, you may be at a wrong level. So normally, if you localize it well, it should be around 90 degree. So your tubular retractor should be straight, and then again confirm with the C-arm that you are at a correct level. And again, another issue is that if your tubular retractor is beyond the skin margin, that is, it has gone too deep down, then also you should be suspicious. You may be in between the two transverse process, especially in an obese patient. So localize them very well, take due precautions. The other cause may be complication, may be bleeding. Usually it is not so severe and not a problem in endoscopic surgery, but rarely you may find brisk bleeding, which is seen in severe stenosis. When you have very severe stenosis, there are angos vessels above and below the segment, and in such cases, when you try to just do something, there is a brisk bleeding. So in such cases, don't try to coagulate, just put in a patties, gentle pressure with patties or Abgel or Surgicel will work. The hematoma may be another complications which is bad, and you should go for proper hemostasis. It occurs usually when you remove patties after you have done the dissection, or you remove the gauze pieces which you have put in cranially, caudally, and laterally during surgery. So after removal of patties, proper hemostasis should be achieved. The other problem which you may come across is incomplete decompression and recurrence. There is a problem and a misconception in mind of surgeon, especially when you start doing advanced surgery. So people talk that you should go for fragmentectomy only. That means remove only smart part of the disc and don't try to remove the most of the disc. It is wrong. If you have a significant compression, like advanced cases which we get in our country, nobody comes with very small little disc fragment. So if you have a very big disc prolapsing out, just removal of a fragment will not work. You have to remove most of the disc, replace it back, and I'll be discussing about the trick how to remove the central disc and the disc which is lying on the opposite side, and make sure that you remove all the element which are responsible for compression, like the disc you have to remove if it is prolapse. You have to also deal the spur which is coming from end plate or hypertrophied facet joint and the ligamentum flavum. So all these culprit, if these are present at whatever level, whether these are central, at paracentral or foraminal, all these must be addressed in endoscopic approach. Now, dealing with the central and a massively prolapsed disc in endoscopic approach, you can remove the ipsilateral disc very well using your straight instrument, but a central disc and the disc which is on the opposite side need to be removed with the angled instrument. So using an angled instrument, you push this disc fragment into the cavity of the disc cavity, and then you remove it from the ipsilateral side. The ligamentum flavum hypertrophy and the lamina of the opposite side need to be removed with the angulation, and it can be done over the top decompression technique. Extruded disc fragment also, if it comes dorsally, can be removed. So the good decompression should give rise to good expansion of thecal sac. Now, this is the step which can be for the younger surgeon, how to remove the opposite side lamina. It may be difficult without removing the base of the spinous process. So you have to angulate your tubular retractor. You have to also drill the base of the spinous process, drill the opposite side lamina, undercut this, keeping the ligamentum flavum intact, and also you can drill the opposite side facet joint medial portion. So the trick is that do not drill the inner portion of the lamina. You should keep the inner portion of the lamina intact, only drill the middle portion, and also keep the ligamentum flavum intact, which will protect your dura. And this thinned out inner portion of the lamina should be removed using Carrison punch, thin Carrison punch. Now, regarding the more operating time in the beginning of your learning curve, when you use drill, because there will be frequent swelling of lens by either a bone dust or a fluid for irrigation or even the humidity. So there should be intermittent. The general principle that you keep on irrigating and do the drilling should not be done in endoscopic surgery. You should go for intermittent irrigation for short duration. Intermittent drilling and intermittent irrigation to avoid frequent soiling of the lens, and try to keep the endoscope as much away as possible. Now, this is a short video showing what are the different causes of lens soiling. Initially, even the fume also can soil your lens. So just simple using a suction will take out the fume. The second cause is the bone dust can also get stuck on the lens tip, which can be removed using the saline irrigation. And the third is even that saline which you are using can drop of saline may be there on the lens tip. So using when the suction tip near the retractor will overcome that problem. So I think the last slide, the causes of instability. If you wrongly select a case, if the patient has out of proportion back pain compared to radicular pain, rule out unstable spine in the beginning by getting a flexion extension x-rays. And if it is there, unstable spine, then you need to fuse. Not only so decompression alone will not work. The facet injury, if you do during surgery, that should be avoided. Only medial portion of facet can be removed. Avoid injuring the paraspinal muscles and the supra or infraspinatus ligament. So I don't prefer, there are people who have advised the midline approach for bilateral decompression, but because it injures these ligaments, so that should be avoided. The other complication, is the conversion to open approach, which occurs when there is unfavorable anatomy, disorientation, inability to do proper bimanual dissection. It occurs sometime, excessive angulation, excessive bleeding, massive dural tear with root prolapse in the beginning of your surgery, and incomplete decompression. So at times you find a very narrow interlaminar space. So what is interlaminar space? You should get a X-ray, plain X-ray, and find out the distance between the lateral margin of the spinous process to medial margin of the facet joint. If it is very narrow, then you are likely to get very much difficulty during surgery. So only expert surgeon should try to do that. In those cases, you can drill part of the spinous process, or at times the spinous process is deviated to one side, to the side where there are symptoms in endoscopic surgery, to the side of lesion. So in that case, you have to address that, or if the facet is very much hypertrophy. So in such cases, you should be careful and go for appropriate technique. So this is the last slide. Discitis, when there is a dead space or collection of blood, or there is a issue of sterilization, because I think although the company people advise autoclaving, but they themselves say that if you use autoclaving of these thing, then the life of this thing is short, your cameras and telescopes. So we use Sidex. So proper sterilization issue for sufficient period is needed. Thank you very much.
Thank you very much, Professor Yadram, for this great presentation. All the presentations today are excellent. We still have our last speaker, and then we will open discussion again at the end of this session, which is complications of spine surgery. Now I give the mic to Professor Kiki Torel to introduce our last speaker, Mazda Kiki Torel.
Thank you. Yes, we are running short of time, so I'll just make a very quick introduction of Mazda. He's my son, so he has to be very good. And he passed from the very he passed from the very prestigious Christian Medical College in Vellore, which is one of the premier institutes in India. He got his MCH from there, and he was awarded a gold medal as the best passing out resident. In 35 years, only 4 people have been given that. What is impressive is that he has published over 100 papers in esteemed scientific journals and textbooks. He went after MCH to do fellowships in US and Canada on complex spine surgery and skull-based surgery. And he's now practicing, and he also went to China to work with Minshu on bypass surgery. He's now working in India in a premier hospital in South Mumbai, and also as a assistant professor in the same institute from where he earned his MBBS degree, that is the Grand Medical College, which also was my alma mater in Mumbai, the oldest medical college in our country. So, here, ladies and gentlemen, this is Mazda for you. He's a prolific writer, also writing in the newspapers, um, uh, trying to demystify the enigma of the brain and spine. So, Mazda, the stage is yours. I don't want to introduce more. I know much more secrets about you, but I don't want to. I don't want to. Okay.
Thank you, Professor Keke for this very exciting introduction for Mazda. And thank you, Mazda, for contribution to our webinars. Actually, we are honored and glad to have you among our distinguished speakers. Thank you very much.
Thank you so much for having me. I mean, it is indeed an honor and a pleasure to be part of such an esteemed group. I'm going to quickly shoot across to the topic, and I'm going to talk on complications in tubular MIS. Dr. Yadav has so very well elucidated the endoscopic problems, but tubular surgery is really whole deal with working through the tube using a microscope. And I'm not, you know, we've seen all these complications are possible: a K-wire breaking, a screw going through the canal, a disc herniating backwards, screws becoming loose, screws missing the rods. But I'm going to illustrate this through a couple of cases. The way we do the basic standard MIS TLIF with using the tubular retractor is this way. We just dock the tube on the facet. Now, the really important thing to note, especially in obese patients, is that you don't dock the tube across the opposite side. Sometimes that is possible. One may even imagine that how can something like this be possible? But any of these things are possible because you're doing it through a 2 centimeter incision, and you have to make sure you're docking on the ipsilateral facet. You know, in really obese patients where you can't even. So we classify obese patients into 2 categories: one in whom the spinous process can be felt, and one in whom the spinous process cannot be felt. So if you do not feel the spinous process, please do a midline marking so you know which side of the midline you're on. Because in one case, I have docked on the opposite side and started drilling that facet until I was completely lost. And it's even harder in the thoracic spine. In my fellowship, I've seen a case where the opposite side was docked onto, and what was thought to be the dura was actually turned out to be the pleura. And then we had a little bit of a disaster doing that. So when you dock, this is the expandable tube that we use, and we can open it up pretty much to expose 2 segments, and we can do a full 2-level interbody fusion along with placement of pedicle screws. And this is what it looks. You know, the reductions are very good. It's like doing an open instrumentation through a tube. This is not using percutaneous screws, and it has extremely good results. You can see a very good reduction of the listhesis, and like Dr. Yadav showed, you can do a very good decompression. But I want to show you this case wherein which even using the tube, you can have a little bit of a problem, and how to identify these problems. This is a 40-year-old guy with severe back and leg pain. You can see that because of his previous trauma, he's got 2 significantly degenerated discs along with listhesis. And we went and did a 2-level minimally invasive TLIF using the tube, and we had an uneventful operation. You can see the incisions are just 2 inches, and we can do 2-level fusions in that much. But I found one screw, I thought that one screw was slightly malpositioned, and this is the L4 screw on the right side. It's almost crossing the midline. And the way to really identify it is if you have 2 screws of the same length, and on your lateral x-ray, if one of them is significantly shorter than the other, and it's a true lateral, you must try and understand that one of those 2 screws is medial. The shorter screw is obviously very medial, but we didn't have any, supposedly we didn't have any problems placing the screw. So I wasn't really sure whether I should remove the screw, reposition it, let it be. I let it be. And post-operatively, the patient didn't wake up with any neurological deficit nor with any pain. But I wanted to really test my suspicion and see whether this screw was really medial. So out of curiosity, I got a CT scan done. And if you notice, this is the right side L4 screw. Now look at the L5 screw. L5 screw is going through and through the canal. It's going through and through the canal, and the S1 screw is good. You can take a look at it again. The L4 screw is fine, but the L5 screw has a medial breach and it's going through the canal. Luckily, this patient didn't have any neurological deficit. The lumbar spine allows for that. The thoracic spine doesn't allow for it. So the question was whether we should go back and reposition the screw, let it be, whether to tell the patient, not tell the patient. So we just let it be. We told the patient that one screw is medially placed, but if he has any symptoms, we will change it. But we have a 3-year follow-up on him, and he's been asymptomatic. This is another lady who had a previous L4 to S1 laminectomy for canal stenosis and now came with severe right leg pain. And you can see that she has a listhesis at L4-5, and L5-S1 is also degenerated. And this MIS TLIF uses a lateral approach. So it's extremely good in someone who's had a previous midline operation, that you don't go through any of the previous scar tissue. And there's a very good central decompression, but you can see the lateral recess stenosis at both levels. And that's what we really address. And we did a 2-level MIS fusion with absolutely no complications. And post-operatively, she had significant resolution of her leg and back pain, and she went home. But 2 weeks later, she came back with recurrence of her pain, and an MRI showed a large subfacial abscess, which I don't have the image of that, but we had to wash it out. So while we say that MIS surgery has lesser infection, it does indeed have a lesser infection, but you do get infections with that as well, and you have to be very careful. This is the only patient who I've had an infection with after MIS where I had to re-explore and wash it out. Luckily, we didn't have to change the implants for her, and post-operatively, she's done well. This is a 75-year-old gentleman, another case with severe back and leg pain, having failed all forms of conservative therapy. You can see an L4-5 stenosis with a listhesis, but the listhesis was stable, it wasn't mobile. And you also see that at L1, he has an intradural tumor. He also had anterior leg pain. So he was symptomatic for both these problems. So we decided to address both of them minimally invasively through the tube. And one person was working at L1-2. Notice the exact position of this tumor. This is the L1 body. The yellow line is the L1-2 disc space. We went through the tube. We didn't find tumor. We angled the tube up and down. We didn't find any tumor. And now, since this was a minimally invasive incision, we were wondering whether we should open it up or we should, just close. We finished the lower L4-5 decompression adequately. And here you can see the post-op MRI. We couldn't find any tumor, so we had to close. We didn't further extend the incision because we didn't know which way to go, up or down. And you can see the L4-5 is very, very nicely decompressed, but the tumor is still there. The tumor is there. However, the tumor is at the lower border of the previous laminectomy. And what, in our opinion, has happened is that our initial positioning is absolutely bang on. But you can see that post-operatively, there has been some shift in this tumor. You can see where the tumor was before and where the tumor is later on. And we had to tell the patient that we feel that the tumor has migrated for some reason. We didn't have a CSF leak in the lower decompression, so it's unlikely that would have caused it. But we had to take the patient back, and we again did a minimally invasive laminectomy at L2, and we were smack on the tumor. We found it, and this is the post-operative MRI. But this required the patient having had another operation. If probably we had done this open, we could have easily extended the incision either one level above or below. But while doing it MIS, we really wanted to be absolutely smack on sure where we were, and instead of just continuing to re-explore, I mean, in hindsight, if we would have just gone one level below, we would have found it. But at that time, it's difficult to predict. So, there could be some reasons for migration. Either it's a real actual counting error. These intradural tumors, you have to be very careful in which position the MRI is taken. If it's taken in a supine position, prone position, just the position of the hands, whether they're up or down in the gantry can make a difference. You have to be wary if a patients have had a myelogram. This patient didn't have one. In the lumbar spine, the lumbar roots are very redundant compared to the cervical or the thoracic, where the chance of movement is almost minimal. And if you've had CSF release, it's possible that these could shift. So it's a good idea probably to use an ultrasound, but if you're doing it through the tube, I don't think we have probes that will allow us to watch it through the ultrasound. So what we've done is we've devised this technique where we put cod liver oil capsules and do an MRI in the position that we are going to operate on the patient. And in over 100 cases of intradural tumors, we haven't had to extend our incision in minimally invasive cases as well. I'm going to go through some of the MIS complications of an MIS lateral approach. Now, this is a patient who's had 2 previous L4-5 discectomy, but still with severe progressive pain. And you can see that the center is absolutely okay. His main problem is severe foraminal stenosis, primarily on the left side at L3-4 and L4-5. So we decided to do a direct lateral interbody approach at both these levels. And we just fused it on one side, even though there was no listhesis, just to ensure that the foramen are open, because he'd had previous 2 microdiscectomies from posteriorly. So this is an excellent approach. A lateral interbody approach is minimally invasive, just using a 3 centimeter incision, and you can jack up the foramen very well. It opens up the space, very, very sleek procedure, and you can put in the screws in the lateral position without much of a problem. He was actually discharged on the first post-operative day with minimal pain and significant improvement in his leg pain. However, on the 4th day, he came back with severe abdominal pain and abdominal distension. And lo and behold, we did an X-ray of the abdomen and it showed air under the diaphragm. Air under the diaphragm means we've had an bowel injury at the time of the operation, and the CT scan shows free air with contrast extravasation in the retroperitoneum. So general surgery had to go in and re-explore it, and they found a perforation of the colon with inflammation and necrosis. He had to have a colostomy, and 3 months later, nonetheless, we were able to close that, and he was devoid of pain. But it's a harrowing 3 months for a 30-year-old guy. It's very important to study preoperatively. We only look at the central portion, but when we are doing a lateral interbody fusion, you have to see at L3-4, there's paucity of retroperitoneal fat compared to L4-5. So, sometimes bowel can get entrapped in your retractor blades, and you may not see it because, and that prolonged retraction can cause ischemia and necrosis. In over 13,000 cases, the incidence of bowel and vascular injury with these procedures is less than 1%, but if it happens to that one particular patient, it's 100% for him. So it's very important to assess the anatomy of the great vessels, as well as when you're doing a lateral approach, and to check, for retroperitoneal adhesions or adequacy of the corridor. And when you're sweeping with your finger, when you do a lateral approach, when you're sweeping, you have to feel the TP and then sweep the psoas anteriorly. So you're not going through the psoas, you're pushing it forward. And you have to be very careful of docking the retractor to avoid ischemia of peritoneal contents, and you obviously don't need to be next to great vessels. This is to prevent a vascular injury. And when you're bringing the retractor out, you have to be very mindful of inspecting all the walls of the corridor. If you notice a complication at the time of the procedure, obviously you have to repair it there and then, but you have to be very sensitive to abdominal symptoms post any lumbar spine surgery. Not only, a lot of people have abdominal pain and discomfort and urinary retention if they've not been catheterized. So don't neglect any abdominal symptoms, and be very, very mindful that, there could be a vessel injury, there could be a bowel injury. Don't neglect those, because if picked up early, you can, prevent sepsis and septic shock, and prevent the patient from crashing before taking the patient down to the operation. You can really do it quickly and salvage a case, and like so for a vascular injury. This is another patient who we decided on a direct lateral interbody approach. And here you can see, he has a scoliosis, he has a foraminal stenosis. If you want to do a posterior approach to address this, you might have to knock off the facet. And if you knock off the facet, you might have to fuse him unilaterally at that level. If you just do an interbody lateral approach, you may not have to. And this patient had a lateral interbody standalone approach with, a very, very good recovery at 1 year in both back and leg pain. But there are other cases that don't do so well. So you have to be very careful in choosing patients for the lateral minimally invasive approach. This is a patient who again has a problem at L3-4. You can see facet infusions, and we went ahead and did a lateral interbody approach, and you can see the good decompression. The foraminal height is increased and significant relief of pain. We did an MRI for him 2 weeks post-op. This is in our early days when we were learning the procedure. We did an MRI for everybody to see assess the level of decompression and to see if we were doing a good job. But 1.5 months later, he came back with severe worsening of pain, both back and leg pain, and you can see that the cage has resorbed into the vertebral body, subsided with a collapse of the foramen, causing him recurrence of his back and leg pain. So we went and took him back and did a minimally invasive laminectomy from behind and put in percutaneous screws, with which he had significant improvement in his symptoms at 1 year follow-up. But this again is important, because if you're doing an interbody, you have to check for osteoporosis. You have to recognize whether your bone is going to be good. And if you're not pressed to do an immediate procedure, then take the time to get a good bone for the patients. Give them teriparatide, give them denosumab, whatever is required to get their bone stock going should be addressed before you do a long. Make sure they're not smoking, etc. And in the last 2 cases, I'm just going to show you a few complications of an MIS deformity correction. And this is a 75-year-old with incapacitating back and leg pain. These were cases from my fellowship time, and you can see there's an adult degenerative scoliosis. I'm not going to bother going into the numbers, but because he was a Jehovah's Witness, they refused to receive blood. And so we decided to stage this surgery in an MIS fashion. And in stage 1, we just did long segment facetectomies with an L5S1 interbody fusion, and that went off okay. And we didn't need to transfuse. And in stage 2, we did a lateral interbody fusion at 2 levels to correct the deformity. And then in the last stage, we put in percutaneous screws using the O arm. And during the last stage, we had an absolutely uneventful time. There was no signal, but once the patient was woken up from anesthesia, though he was intubated, he was not moving the right leg. You can see the right leg values as recorded, significant weakness in hip flexion and extension, and in ankle dorsiflexion as well. So this is very, very unnerving. We got a CT scan which showed that the T12 screw was going through the canal, and this is, mind you, with the O-arm guidance. and the L1 screw also had a medial breach. So we had to talk to the family, take the patient back and reposition those screws. And luckily his power improved immediately. And at the time of discharge, 2 weeks later, he had regained complete function. And you see, when we went back to do an MIS, we didn't have to open up the whole incision. We just opened up the top portion of the incision and then connected to the rest of the system using a side connector. So you have to be very careful of even using the O-arm. It's not free of complications. And there is a less than 1% failure of intraoperative monitoring as well. So you have to be mindful of using a combination of techniques and understanding why sometimes neuromonitoring also does not pick up neurological deficits. I don't want to go into details of those reasons, but I'm going to end with the last case, which is a 15-year-old girl with a progressive idiopathic adolescent scoliosis with severe pain. And you can see she has a double major curve with not amenable to correction with a brace. And because of the cosmetic deformity and pain, we went ahead and decided to do this. We did bilateral facetectomies. You know, when two people working through the tube at each level, they do it together, it's not as cumbersome. So we did T3 to L3 facetectomies, and then using again the O-arm, we put in percutaneous screws. And this time the navigation, the neuromonitoring was able to pick up that while putting the T9 screw, we had loss of MEPs in both lower limbs. And we used the usual protocol of raising the blood pressure, giving steroids, giving blood. The O-arm spin didn't show. The O-arm spin didn't show any breach. So instead of adjusting any screw, we woke her up. We do a wake-up test and under anesthesia, but there was no movement in the leg. So we just decided to remove all the screws. We didn't know whether it was traction on the cord, whether there's a hematoma forming somewhere, whether there's a bony fragment in the canal somewhere. So we just removed all the screws, and luckily the monitoring returned to normal. We have a very, very standard checklist of intraoperative neuromonitoring that everybody should use. It's available. It was published by Lenke's group, and you have to be very, if you have this, you know, step by step exactly what to do when you have a drop in monitoring signal. So we repeated a CT scan that didn't show any fragment in the canal. We did an MRI that didn't show any hematoma. So, and couple of days later, when her she was okay, we went back. We did a hemilaminectomy at the level at which we got a deficit to make sure there was no breach. And then we again went ahead and put in a instrumentation. This time we didn't use the O-arm, we just used standard X-rays, and we were able to get a decent correction for her. So while the O-arm definitely and any form of navigation definitely has its perks, you have to be very mindful of making sure that it's always working well. And the way to do it is, you know, you have to have the reference frame within 3 levels. So if you have your reference frame at L5S1 and you're doing a T2-3 navigation, there is a chance that you're going to be offbeat. So it works best within 3 anatomic levels. So it's, you do those 3 levels and then you re-register and you do it again, and that's the way to maintain you know, the greatest accuracy. So that's it with my cases, and I think this gives you an overview of all kinds of MIS cases with their complications, the posterior approach, the lateral approach, the deformity correction. I didn't want to go into dural leaks and all of those things which are standard and actually much easier dealt with MIS than open, because the chance of having a CSF leak coming out of the skin is much less when you do an MIS approach. But I think this holistically covers more or less the complications that we faced. But again, it's a learning curve, and we get better with more we do and how we understand treating these problems.
Thank you, Mazda, for this very, very interesting presentation. And actually, all the talks today are outstanding. And now we open discussion. I can see that many questions in the panel, whether in the Q&A or chat panel. And Professor Kiki Turrell will start by questions, and then we open discussion among all panel.
Thank you, Nasser. Thank you, all of you, Salman and Yadav and Mazda, for this, again, a very extensive session. Now, Salman is still there? Salman
Yeah.
around? Yeah, okay.
Yes.
So, Salman, what you have shown is a very interesting thing is about this collapse of the vertebral body and in tuberculosis spine. And the lessons that we learned was to do a CT scan. And I thought it is for all these kind of patients, especially for inflammatory and trauma, we would do a CT scan in every patient. So is it not the normal policy to do it, or it is or it is only done when you have some particular suspicion? Do you
No,
not use a CT scan for all TB spines?
No, and it's not done for all TB spine. It's for any one that we are intervening. So when we are doing intervention or we are thinking is the thing getting worse, then we do it. But in majority of the patients, obviously conservative treatment would sort things out.
No, I'm talking about surgically treated
yes,
cases.
Definitely in every case it's done. This particular case is just like many other things known to the director of the hospital and was admitted via a fast route and was pushed into the OR as soon as possible, saying, oh, weakness is happening, sphincters have gone. So I think, and it was our fault as well, that before putting the patient to sleep, we did not make sure that CT was not done. So I think that was completely our fault, that we should have made sure that it had happened. Usually, even you can get away in thoracic spine because of your rib cage, your jacket that's protecting you from the, that's making sure the stability is still there. So you'd get away with 4 screws in majority of the times in TB, unless you're correcting kyphosis in big way. And here in this particular case, I think we were too ambitious trying to correct it through just by 4 screws. So I think it was our fault in 2 ways. So that's why I wanted to show this particular case. Also, there was a question about infected titanium implants. Now, for last 10 years, it's been shown again and again that titanium implants do not harbor bugs per se, except Propionibacterium, which can in long run cause low-grade infections. So really, putting in titanium implants, cages is not a problem in infected spine, especially in TB. It's not a problem, and we have shown in our 400 cases that we published a couple of years ago is that there was not a single case in which we had a secondary infection besides TB, and majority of the cases they settle down. So it's one of the easier disease to treat, unlike a degenerative process where patients could have a lot of other problems as well besides having the primary disease.
So you would still prefer to do a posterior approach, and you are avoiding doing the anterior approach in most of the patients. And a hybrid, that means an anterior and posterior approach, you are obviously not recommending. Is it correct?
That is correct. What happened when I came back to Pakistan 20 years ago, I was doing all these cases from front, just like we do it in Europe and US. I did fellowship in Barrows, and that's what we did there. But over the years, they change, I change, and I realized that we can do all this from behind. So in majority of the cases, we want to do this from behind. Second thing is, once you stabilize from behind, in majority of the time, that all that granulation tissue anteriorly forms a thick tissue which turns into bone in the long run. And really, you don't want to lose all that bone that you're going to be digging out if you operate anteriorly. So there are obviously pros and cons from both sides, but it works pretty all right if you operate from behind in majority of the cases.
The good thing about TB spine, which I have also seen in my experience, is that the neurological deficits, they appear devastating at the beginning. Sometimes they come with complete paralysis, but they improve dramatically over a period of time. Of course, they do show great improvement. And even people who have been paraplegic for long duration, long periods of time, show a great recovery. What has been your experience with
Same,
TB spine?
same. I think, in our cases that we published, we found that, 10% of these patients had no power at the start. And except one, the patient had a brain TB and, and did not survive because was completely frail, was like 25 kg weight. And, our physicians could not just retrieve that patient, and that had TB brain itself along with POTS. So I think in that particular case, obviously it wasn't possible to salvage, but nearly always, if you go in, touch the spine, come back, patients improve. So it's a disease that's very friendly to us compared to a degenerative process where you may be in trouble for a small disc for a long period of time. And the patients obviously may not be that happy compared to the TB patients, which are very, very happy, and they really admire you for your work.
Yes. So, Nasser, am I missing any questions from the group?
I think still questions.
For Salman?
Yes. In this 74 years old man with tumor, with migrant tumor, would it be due to difference in the direction of the magnetic field? In other words, and positional artifact? He's speaking about one of the cases presented.
This is by Mazda, I think.
Yes, I think so.
I don't think it's an artifact. It's definitely some movement, because it may depend on how the MRI has been taken. But the fact is that the tumor was not seen at L1 and it was seen at L2, and I think it's possibly related to the position in which the MRI is taken, but I'm not sure. It's a question that we're still grappling with. It was definitely not a disc, as someone else suggested in the next question. It was not a sequestered disc that had migrated. It was a tumor because we removed it eventually, and we saw it arising from the nerve root, and we sent it for histopath, and it came out to be a schwannoma. So it's definitely not a disc, but I mean, these migrations of tumors have been reported in a small number of cases. We wrote up this paper and published it. So we've done a literature review on it as well.
Another question, looking backward, what could you have done to identify the tuberculous bodies before surgery?
Yeah, Nasir, I've already answered that question.
Okay.
There is another question regarding incidence of pleural injury and pneumothorax after spinal fusion, and the fact and the fate of these.
Let me read the question first, asking about the incidence of pleural injury and pneumothorax following spinal fusion, and the fate of the patient if this complication takes place.
Actually, when we are doing anterior thoracotomy, obviously it's a lateral approach generally, and it is a straightforward procedure. It's one of the procedures that we teach our first-year residents when they're starting out. And you use it in many ways. Obviously, trauma, infection, neoplasms, whatever you name it, we use it. But obviously, when you're doing big surgeries, then we open up the pleura, and obviously we close it at the end, and we leave a chest tube behind. So pneumothorax is not an issue because we leave a chest tube behind. In certain cases, when you've got a single or only 2-level POTS, you could have done this anteriorly and retropleural approach, and that's possible, and it's a simple, straightforward procedure. But many a times after trauma, it's already torn. And in neoplasm, it's eroded, and so you may be causing multiple perforations anyway. So in some of those cases, you may end up putting in a chest tube. And this is straightforward. It's like any thoracotomy you do, and the outcome is very good in these patients. I have not seen a single problem in the patients that we've operated with thoracotomy.
Salman, another question. I don't know if you already answered. Would you throw some light on the care of an infected titanium implant? Is it the same like other implants?
Yeah, I answered that already, that yes, it's different.
Another question to Professor Salman. You said to go right to the anterior cortex when fixing the spine. Is this in reference to the drilling of the pedicle with the pedicle probe, or is this about the length of the screw. Secondly, on this same issue, a number of publications have stated that screws that are 2/3 of the anteroposterior length of the vertebral body are adequate biomechanically. What is your comment on this, sir? This is pertinent because of the risk of perforating the anterior cortex and visceral injury.
Yeah, actually, I mentioned it when I talked about going as far anteriorly as possible. Is, you know, the bigger size screw, the thick screw you're going to put in, the best results you're going to get. And this is especially in relation to alpha, L4, L5, S1 we are talking about. So this is in relation to L4, 5, S1, and this was if you're going to be correcting any deformity, if you're going to be putting in a lot of pressure on it, then you need to have as wide screw as possible. And these are big screws, and as long as possible, if you're starting out laterally and coming in anteriorly. But you know, you try obviously not to perforate the cortex if at all possible at L4, 5. S1 we sometimes do when we put in medial screws, but especially in that case as well, we need to be wary that there are structures, nerve root running anteriorly and a large red stuff running anteriorly that you need to avoid as well. So you know, I especially mention it regarding L4, L5, and S1.
Thank you, Professor Salman Sharif. I think, Kiki, we finished all the questions. Would anybody like to say any comments?
I think there is one question also about what about the ragged tear which happens?
Yes.
And lateral tear, how it happens, repaired. Means dural, I think he's talking about if there is an extensive injury of the dura and you have hardly anything left. So in such cases, you can put in dural substitute or fasciolata on if you don't have dura for suturing left with dural substitute and then fat and then tissue glue. So it works. And if you can find 1 or 2 or 3 stitches at the margin, which will hold the dural substitute or fasciolata there, that will be nice. About the lateral tear, just putting in fat there and maybe dural substitute and tissue glue will work. Yes.
Thank you. Any other comments?
I think you're just grateful for what a wonderful performance by the 2 youngsters.
Thank you, sir. Thank you.
Okay, I think Professor Kiki Turel, it's time to say your closing remarks before I close the session.
Yes, I think we've had a very enjoyable 3-pronged attack today, starting with the skull base and neuro-oncology, skull base, and finally spine. And we had wonderful speakers on each of these segments, each one having a vast experience. And what is interesting about these seminars on complications is that people are now not at all afraid of coming on the stage and openly discussing about their problems that they have faced. And this is a kind of an exchange of knowledge and personal experiences, which is making us wiser. And now it has become, at one time, I remember people used to say we have no problems and we have no complications and our results are excellent and nobody dies, nobody gets infected. Now we know that this is completely untrue. And with this complications platform giving the space for all these people, it looks like we have now come to a level of maturity where we realize that complication is an inevitable part of surgery, and that it's better that we accept it and we learn from it. And we learn not only from what we have experienced, but also equally much from the experience of the others, which is why we need to have these kind of group meetings where everyone can exchange their ideas and exchange experiences for the betterment and the understanding of all. And most important, for the younger generation of neurosurgeons who have admired and worshipped these stalwarts who have been practicing and writing and demonstrating surgery on how I do it. Once in a while, they would come up with a case to show how I would not do it or how I would do it better the next time. So thank you very much for these confessional papers by everybody. And I think we have learned a lot from each other. Until we meet again, our next complications meeting is going to be in the end of July, 30th July. And again, we will be having the same discussion as we had last time, major complications following so-called minor surgeries. And minor surgeries means number of things, from shunts to ventricular drains, to convexity tumors, to non-eloquent gliomas, ACDF, simple lumbar disc surgery, carpal tunnel decompression. So there are a number of minor procedures, so-called minor procedures. Nothing is minor. And we've had a overwhelming response last time. And even for the second conference, one webinar that we do now, we already have received a large number of papers. So please continue to contribute to this participation on complications. Thank you very much.
Thank you, sir. Thank
Thank
you.
you, everybody. Bye-bye.
Bye-bye.
Thank you, Dr. Nasser. Thank you for allowing the complications committee to participate with you. Thank you.
Professor Nasser, I think you are muted, sir. Muted.
Thank you, Professor Kiki Torel, and thanks to all our distinguished speakers. The session was excellent and all the webinar was very successful. Thanks to all of you, and we see you again in another occasion. Thank you very much, Yadram. Thanks to all of you. Thank you.
Thank you, sir.